handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hello, good day. I'm your teacher for this organ system integration, part 2 for gastrointestinal system. I'm Dr. Eric Eusebio Calderon. Let us first start our lecture with a prayer. Lord, true source of light and wisdom, lofty origin of all being, graciously let a ray of your brilliance penetrate into the darkness of my understanding and take from me the double darkness in which I have been born, an obscurity of both sin and ignorance. Give me a sharp sense of understanding, a retentive memory, and the ability to grasp things correctly and fundamentally. Grant me the talent of being exact in my explanations and the ability to express myself with thoroughness and charm. Point out at the beginning, direct its progress and help in completion. So, our topic for today is gastrointestinal integration part 2, wherein we're going to integrate some of, not all, but important topics in gastrointestinal pharmacology, pathology, with correlations to internal medicine and microbiology. So, these are the following diseases that we're going to tackle for today. So, for the diseases of the esophagus, we're going to discuss the different inflammatory and related disorders of the esophagus, such as the following. Of course, the most common is your gastroesophageal reflux disorder, followed by Barrett esophagus. Some of the infections, just like your candidiasis, herpes simplex infection, and CMV infection, and of course, your carcinoma of the esophagus. So, in correlation to internal medicine, let us discuss some of the signs and symptoms that we can correlate well when we discuss the topic of esophagus. So, here are the different terminologies lifted from Harrison's Harrison's Principles of Internal Medicine. Isa-isayin natin, no? Heartburn, also known as your pyrosis. There is a discomfort, or should we say burning sensation behind the sternum, and GERD is the most common cause. Followed by regurgitation, wherein there is an effortless return of food into the pharynx. Sometimes the patient may report sour burning fluid in the throat, usually aggravated when you bend, when you belch, or any maneuver that can increase the intra-abdominal pressure. Chest pain, we associate chest pain with diseases of the esophagus because the heart and the esophagus share the same innervation. So the discriminative ability to tell if this pain is secondary to GERD, for example, or should we say cardiac in origin is different. So there is always a correlation to that. Odynophagia or odynophagia rather, there is painful swallowing, more common in pill esophagitis or infectious esophagitis than the reflux esophagitis or GERD. Globus sensation or globus pharyngeus, or in Harrison's, ang tawag dito is globus hystericus. There is a feeling of lump in the throat, pwedeng dahil may anxiety yung patient or may OCD yung patient, but attributable to experience most likely associated with gastroesophageal reflux disorder. Water brush naman, ano ba yung water brush? Parang meron kang excessive salivation resulting from vagus nerve stimulation. So these are the signs and symptoms that we can encounter upon our discussion for the different diseases associated with the esophagus. So let's try to answer this question. A 30-year-old woman presents to her physician complaining of chest pain and difficulty swallowing. Results of ECG and X-ray of the chest were normal, but the following image was seen during a barium swallow. Which of the following action is most likely absent in this patient? So hindi ko na pakita image. Pakita natin, the answer is relaxation of the lower esophageal sphincter, which is described in case of achalasia. So in achalasia, balikan natin. Achalasia, there is failure of the lower esophageal sphincter to relax. Sorry, may typographical error here with swallowing. Etiology, we have primary etiology or secondary etiology. Primary, we do not know, no? Idiopathic in nature. No? Secondary cause, for example, is your Chagas disease or Trypanosoma cruzi infection. Trypanosoma cruzi infection, your South American trypanosomiasis. Presentation, usually the patient presents with progressive dysphagia. So sa simula, hindi siya makalunok ng solid, then eventually hindi siya nakakalunok ng liquid, no? So the triad of achalasia, do not forget, both in Robbins, both in Harrison's, we have the incomplete lower esophageal sphincter relaxation, increase in the tone of the LES, and aperistalsis of the esophagus. Again, pag sinabi nating primary, hindi natin alam, hindi natin tukoy kung saan talaga nanggaling. Probably there is degeneration of the ganglion. Secondary, the most common attributable to that, theoretically, we have your Chagas disease, wherein the trypanosoma infection will cause destruction of the myenteric plexus. You remember, your myenteric plexus is essential for muscular contraction. So, gross picture, esophageal dilation proximal to the lower esophageal sphincter, and the diagnostic of choice, you select your manometry that will show uncoordinated or absence of peristalsis with high LES pressure. All right, or high LES pressure. So this is the classic barium swallow, the bird's beak appearance. So in some books, they will call it the rat tailing appearance. So microscopic findings, loss of ganglion cells in the myenteric plexus. Treatment is lower esophageal balloon dilation or myotomy. And there is a predisposition with achalasia in increased chances of having esophageal carcinoma. Esophageal carcinoma. So very important to remember achalasia. One of the high-yield board correlates and tested topic, your achalasia. Next, a 50-year-old man from Tondo with a history of drinking a bottle, 1 to 2 bottles of vodka for the past 25 years, present to the ER with massive hematemesis. He took antacid for acid reflux, but wala siyang other known medical problems or medications. Temperature, normal. Temperature, pulse rate, tachycardic, respiration rate slightly elevated, and blood pressure is dropped at 80/40 millimeter of mercury. Physical examination reveals regular rate and rhythm with no murmurs, and his lungs are clear to auscultation. There is no abdominal tenderness or distension, and bowel sounds are present. His stool is negative for blood. Which of the following is the most likely diagnosis of the patient? Okay, so this is the best time for you to answer practice questions. This is the best time for us to integrate what we've learned from the basic sciences. Pato, pharma, physio, these are the basic sciences that we should learn how to integrate. So the correct answer here is most likely the patient being an alcoholic is having an esophageal laceration. Esophageal laceration. Yes, you are correct. Esophageal squamous cell carcinoma could cause ulceration of the esophagus, but massive bleeding is very uncommon to this case. Okay, esophageal stricture is typically caused by scarring from reflux, caustic ingestion, or maybe the patient is having scleroderma. No, scleroderma. So the best answer for this is esophageal laceration. All right, let's move on. Okay. This is your Mallory-White tear. Your Mallory-White syndrome, no? Always associate this with alcoholic patients. There is a linear laceration at the gastroesophageal junction produced by, what is the keyword? Severe vomiting or severe vomiting or severe retching. The most common cause is acute alcohol ingestion, or shall we say the patient is alcoholic or there is alcoholism. Presentation, usually this linear laceration will present with hematemesis, Complications is Boerhaave syndrome, wherein the gastroesophageal junction is separated. Your Mallory-Weiss syndrome. So remember, your gastroesophageal reflux disorder, it results from distinct anatomic and physiologic disruptions of the esophagogastric junction. According to Harrison's, we have the transient lower esophageal relaxation, hypotension of the lower esophageal sphincter, and anatomic distortion of the esophagogastric junction. Just for example, wherein there is case of hiatal hernia. And ano ba yung mga ibang risk factors, no, that may exacerbate your GERD, your gastroesophageal reflux disorder? Abdominal obesity, pregnancy. Both of this, what is the similarity? They present with an increased intra-abdominal pressure. There is delayed gastric emptying. So mas matagal, no? Mas matagal yung pagkain, mas mataas yung abdominal pressure. Gastric hypersecretory states. Duodenogastric reflux, in some cases, bile contents are being regurgitated, and disruption of esophageal peristalsis together with gluttony. Sobrang takaw, no? This can all exacerbate GERD, or gastroesophageal reflux disorder. Again, what are the common manifestations? Mayroon kang burning pain, relieved by antacids, substernal pain, heartburn or pyrosis. Again, aside from the esophageal sphincter, excess use of alcohol, tobacco, caffeine, anything that can lower the esophageal sphincter tone can cause your GERD. Scleroderma, you think of connective tissue disorder, pregnancy, and some cases, gastroesophageal reflux disorder can exacerbate your bronchial asthma. All right. So just to add, what are the alarm features for us to add in the GERD spectrum? If the patient is already greater than 55-year-old, there is presence of unintended weight loss, GI bleeding, anemia, family history of upper GI cancer, progressive dysphagia, and persistent vomiting. These are considered alarm features for patients manifesting with GERD. So these are the different spectrum of injuries associated with gastroesophageal reflux. These pictures are lifted directly from Harrison's Principles of Internal Medicine. You will see here that there is erosive esophagitis, and patients will present with stricture. You see here chronic erosive esophagitis, Barrett esophagus, wherein there is intestinalization or intestinal metaplasia, a pre-malignant lesion, and followed by adenocarcinoma usually that's usually of adenocarcinoma of the lower third of the esophagus. Okay. Another important factor that we should consider, just to touch your microbiome, we have your infectious esophagitis or infectious esophagitis. You will see here, this is your herpetic punch-out lesion secondary to herpes simplex virus infection. We have also the cytologic intranuclear lesions, giant nucleus of HSV, and also your CMV infection. So these are some of the following viruses that might cause infectious esophagitis aside from the mechanical causes that we've mentioned earlier. So, in a nutshell, let's try to touch pharmacology. So, you should remember that Candida albicans being a fungi in origin, a fungi by itself, key manifestations will include oral thrush, white plaques with friability. Yung kapag ginamitan mo ng tongue depressor, yun yung automatically, hindi naman automatically, usually they bleed. Then the treatment for that is oral fluconazole, which is a steroid antagonist. We use 200 to 400 milligram once on the first day, followed by 100 to 200 milligram for the next 2 to 3 weeks. Another one you might want to remember is the nystatin swish and swallow preparation. No? Ginagamit din natin yan sa oral candidiasis. For herpes simplex virus, your Cowdrey type A, does it ring a bell? Yes, your Cowdrey type A inclusion bodies, a correlation to micro, we use your acyclovir. A general rule when you're trying to make a drug work for viral infections, remember in general that antiviral medications are prodrugs. What does it mean? Being a prodrug, they require activation via phosphorylation. There is an activation via phosphorylation, and we have 3 steps. The first step is committed by the virus itself, and the next 2 steps are committed within or by the humans themselves. So what does it mean? In order to attain the effect of the antiviral medication, it is far more so important to consider that the viral infection should be active. For example, if you're trying to give acyclovir 200 milligram, 5 times a day for 7 days, it is imperative that the lesions are active because of the first requirement, phosphorylation by the virus itself. Cytomegalovirus infection, the CD4 count of less than, does it ring a bell? CD4 count of less than 50, you're going to suspect CMV infection. So usually CMV is an age-defining illness. So usually they present with serpiginous ulcers and pathognomonic large nuclear or cytoplasmic inclusion bodies. The drug of choice, ganciclovir. Side effect of this ganciclovir, bone marrow suppression. If the patient cannot tolerate the ganciclovir because of the bone marrow suppression, you can give another alternative. That is, yes, you're correct. This is a non-nucleoside drug, that is foscarnet. Foscarnet. So you see here the Barrett's esophagus. This is the Barrett's esophagus is simply the replacement of the lower third of the squamous epithelium of the esophagus. You recall in histology that your esophagus lining, we have the stratified non-squamous epithelium. And with Barrett's esophagus, because of the chronic reflux, one of the predisposing factor to have Barrett's esophagus is the reflux or chronic GERD, as if, hindi, anong compensation ng lower third ng esophagus is gagayahin ko yung histological feature ng stomach, magiging intestinal type siya, no? Magkakaroon ng intestinal metaplasia. Okay, that is the intestinalization of the or esophagus with Barrett's esophagus. That is due to chronic GERD. And take note, Barrett's esophagus is a pre-malignant lesion associated with esophageal adenocarcinoma. Esophageal adenocarcinoma. So you see here, this is the foveolar cells. Your foveolar cells wherein there is an admixed number of your goblet cells, right? These are your goblet cells, and these are clues that you're looking at an intestinal metaplasia, your Barrett's esophagus. Okay, that's your Barrett's esophagus. Another picture lifted from Robin's pathology, you see here, this is the normal esophagus. This is the paler Barrett's esophagus, and you will note from here this histologic section from left to right of the image. You see here that this is a squamous epithelium replaced by intestinal metaplasia, wherein there is presence of your goblet cells. And that is how you diagnose Barrett's esophagus. Endoscopical findings together with biopsy, usually prompted with GERD symptoms, and the treatment, of course, aside from medical, is surgical resection and photodynamic therapy. Barrett's esophagus. Next question, a 40-year-old Filipino male presents to the department complaining of burning retrosternal chest pain. After meals, his pain is relieved by antacids. The patient's ECG is normal and his X-ray of the chest is remarkable for a hiatal herniation. The patient is at risk for developing which type of cancer? Which type of cancer? So let me review again. So what's your diagnosis? The diagnosis is yes, hiatal hernia. And hiatal hernia can predispose the patient to, you're correct, if we're going to answer esophageal adenocarcinoma. Kapatid, na unang question, no? So let's try to recall. What is a Krukenberg tumor? Yes, your Krukenberg tumor, there is bilateral involvement of the ovaries with metastatic stomach carcinoma. Of course, the correct answer is Barrett's is the correct answer here. Letter B is the correct answer. Esophageal squamous cell carcinoma is usually associated alcohol, smoking. Non-small cell lang adenocarcinoma, smoking, no? Smoking. Gastroadenocarcinoma, usually, what are the risk factors for gastroadenocarcinoma? H. pylori. The most important cause of gastroadenocarcinoma is H. pylori. From the food we take, nitrosamines, no? Mga food preparations, excessive salt, low fiber, low fruits, low vegetables, patients with achlorrhea and chronic gastritis. So this is your esophageal adenocarcinoma. You will see here this picture from Robbins. You will see here this is an exophytic mass, of esophageal adenocarcinoma. Usually this is back-to-back presentation of back-to-back glandular presentation, mucin producing. There is a background of Barrett's esophagus and long-standing GERD, and commonly, in terms of epidemiology, this is 7 times more common in males than in females. More common in males than in females. Your esophageal squamous cell carcinoma, usually they present with, you see here in this image, sorry, I'll just use a highlight for this. For a while. Okay. So you see here more of a stricture in presentation. There's a stricture. You see here nest of malignant cells. Your nest of malignant cells. In terms of epidemiology, male preponderance 6 times more common in African American. And what are the risk factors? These are verbatim according to Robbins. Alcohol use, tobacco use, poverty. Yes, poverty is as a risk factor. Caustic ingestion, achalasia, Plummer-Vinson syndrome, some books, Rubin's pathology. Ibang pangalan nito is your Patterson-Kelly-Brown, syndrome. Signs and symptoms usually adenophagia and dysphagia. Okay, so usually this presents with insidious in presentation, adenophagia, difficulty in swallowing, and there is obstruction. Siyempre, kapag hindi ka nakakain, patients will not eat, no? Less likely to eat, and there's weight loss. because of less likely to eat and of course of the presence of the tumor. There's extreme weight loss and debilitation result from both impaired nutrition, yung sinabi ko, and effects of the tumor itself. So this is your squamous cell carcinoma. Next. So in a nutshell, this table represents the different comparison between the two, your squamous cell carcinoma, which is the more common esophageal cancer in the world, which affects the upper two-thirds of the esophagus. And the usual risk factors include alcohol, hot liquids, hot tea, yung mga nababasa nyo dati, no? Caustic strictures, smoking, achalasia, Plummer-Vinson syndrome, esophageal web neck, iron deficiency anemia, and history of previous radiation therapy of the neck. For example, radiation therapy of nasopharyngeal carcinoma, for example. How about adenocarcinoma? Adenocarcinoma affects the lower one-third of the esophagus, and most commonly it is attributable to chronic gastroesophageal reflux disorder with Barrett's esophagus, smoking, obesity, and achalasia. And theoretically, this is as the most common cancer in the United States, your esophageal adenocarcinoma. All right. So key points to ponder lifted from Robbins. Achalasia is characterized by 3: incomplete less relaxation, aperistalsis, and increased LES tone. Esophagitis can result from chemical or infectious. Infectious, we have discussed earlier, HSV, CMV, Candida albicans. Yes, you're correct. How about the most common? Still the most common cause of esophagitis is GERD. Barrett's esophagus is a pre-malignant lesion usually associated with adenocarcinoma. And esophageal squamous cell carcinoma, we have the different risk factors. We have mentioned alcohol, tobacco, Plummer-Vinson syndrome, Patterson-Kelly-Brown, and caustic injury. So just to correlate with anatomy and histology, just remember, of course, the lymph nodes, no? The lymph nodes. Of course, in the upper third of the esophagus, it is drained by the cervical. So doon ang metastasis niya. In the middle third, of course, mediastinal, paratracheal, and tracheobronchial nodes. In the lower third, gastric and celiac. Most adenocarcinoma, distal one-third. Half of the squamous cell carcinoma, middle third of the esophagus. All right, that's for the cancer of the esophagus. Now let's proceed to the diseases of the stomach. So we're going to touch a little bit of your gastritis, both acute and chronic, your peptic ulcer disease, and of course, the malignant tumors. So this figure is lifted from Robbins, just a recall or a review of the different factors that should be involved when we're going to discuss gastric injury. So it is important to take note the normal physiology first. So remember, we have this continuous mucin layer of mucus. This mucus that will protect, that will protect the gastric mucosa when a particular substance will try to touch the surface of the mucosa. We have the mucus layers that have phospholipids and prevents large food from directly touching or in contact to that. Of course, do not forget other defensive forces. We have the continuous layers, your surface mucus secretion, bicarbonate production, your blood flow that will give nutrients, oxygen, and it will also wash away the influx of gastric contents going to the lamina propria. And of course, do not forget the regenerative capacity of the epithelium together with your prostaglandin. Your prostaglandin is very essential wherein it's very correlated to pharmacology in terms of NSAID use. So with NSAIDs, it will decrease prostaglandin. So take note that prostaglandin is very important for bicarbonate and mucus production that will coat the surface of the stomach. In cases of NSAIDs, NSAIDs will inhibit prostaglandin synthesis. So the common side effects associated from NSAID use, aside from acute kidney injury, is your gastritis. No? Remember, two most important side effects of NSAIDs. First, prostaglandin. Just take note of prostaglandin. It is essential for mucosal surface coating. Next, in the kidney, your prostaglandin is essential for afferent arterial dilation that will promote the glomerular filtration. So what is the net effect if we're going to block prostaglandin synthesis? Acute kidney injury and gastritis. That's it. That's how you correlate pharma with physiology. Now, do not forget also that other injurious agents I've mentioned earlier, we have your NSAID, H. pylori infection, one of the most celebrated infections in the world that can cause gastritis. Cigarette smoking, with cigarette smoking, it will cause vasoconstriction. There is decreased blood flow going to the stomach, to the organ. Hence, there is ischemia. There is decreased blood flow, isn't it? Gastric hyperacidity. For example, in cases of a Salinger-Ellison syndrome, wherein they're in gastrinoma, excessive hydrochloric acid production, and duodenal gastric reflux. Do not forget that it can lead to necrosis, presence of your pro-inflammatory mediators, granulation, and of course, scarring leading to fibrosis. All right, so in a nutshell, that picture explains the patho of gastritis. Now, let's move on to these different factors. Sinulat ko lang, mucin secreted by foveolar cells, the continuous layer, and replacement no, of the foveolar cells and the rich vasculature. Of course, these I mentioned earlier, these are the disruptive factors that can cause injury to the gastric mucosa. NSAIDs, H. pylori, reduced bicarbonate production. Another one, in particular to the elderly population wherein mucin production is less and there is a greater manifestations of your arthritis wherein the patients will have to take NSAIDs. Both of these are contributory factors to achieving or having your gastric injury. And of course, decreased oxygen delivery. So let me just define gastritis. Wherein there is presence of inflammatory cells, we call it gastritis. If there is none, you call it gastropathy. Do not forget that there should be presence of inflammatory cells in gastritis, and we call it gastropathy if there is none. This definition should be reserved for histologically documented inflammation. This is verbatim coming from Robbins pathology. Actually, there is no typical manifestations of gastritis. It depends on the clinical findings of the patient. It is very important to correlate histologic findings of gastritis, the clinical picture of abdominal pain, okay? We have dyspepsia or endoscopic findings noted on gross inspection before we can tell the true diagnosis. So, it varies, not typical no, manifestation of gastritis. So, just to create some emphasis, this slide with stress-related mucosal diseases. So, we have the most affected, we have the critically ill patients admitted to the hospital because of their condition and as well as they are taking so much of the medications. And complications of your gastritis will include bleeding, first bleeding followed by perforation, and of course, there is obstruction. You have learned that also from surgery. And the most important prognostic factor the patient can thrive with this condition is the ability to correct the underlying condition. And of course, the TPI may also blunt the effect of stress ulcerations. So in a nutshell, let's try to differentiate the two most common associated stress-related injury, stress-related mucosal diseases. We have your Curling's ulcer and Curling's curl the iron. Curling the iron, you think of burns. With burns, there is decreased vascular flow, decreased blood flow, can lead to ischemia, can lead to hypoxia. So there is Curling's ulcer. In patients with increased intracranial pressure, or shall we say intracranial injury, there is stimulation of the vagal nuclei. And with this vagal nuclei, there is an excess of acetylcholine production that will cause hydrochloric ion, hydrogen ion production. So cushion, always cushion with brain injury. So that's how uh, you remember the two stress-related mucosal diseases. So next, we have to define what are the different classification of gastritis, and this uh, this image is lifted directly from Harrison's 20th edition. So we see here acute gastritis and we have chronic gastritis. In acute gastritis, still H. pylori infection, other gastritides, chronic atrophic gastritis. Of course, we have your autoimmune, 10% of the 10% of the chance na nagkaroon ng chronic gastritis. And of course, the most important cause of chronic gastritis is an infection, H. pylori. H. pylori infection. So, so you see here, with acute gastritis, the most common cause is still infectious in origin, and that is your H. pylori Helicobacter pylori infection. In acute gastritis, there is a transient mucosal inflammatory process that the patient sometimes may be asymptomatic or can cause variable degrees of signs and symptoms. For example, the patient can present with epigastric pain, with nausea and vomiting. In severe cases, the acute gastritis can also lead to mucosal erosion, can lead to ulceration, hemorrhages, hematemesis, melena, or early massive blood loss. Phlegmonus is rare and potentially life-threatening. Okay? Other etiologies can include streptococci infection, staphylococci, proteus, Haemophilus species. And again, of course, if we're going to think of immunocompromised individuals, you're going to think of these HSV, CMV. These are possible age-defining illnesses. What is the hallmark of acute gastritis? The surface epithelium is intact. Somehow, there is slight vascular congestion and some slight of an edema in acute gastritis. So in acute inflammation, remember there is erosion on hemorrhage of the gastric mucosa due to breakdown of mucosal barrier. As I have mentioned earlier, chronic aspirin. Aspirin is one of the most potent, NSAID. That is a prototype NSAID that can cause destruction of mucosal surface secondary to prostaglandin inhibition, alcohol use, smoking, post surgery, burns, ischemia, curlings, Cushing's, uremia, and chemotherapy. This can lead to gastritis. Common presentation, usually epigastric pain, gastric hemorrhages, hematemesis, and melena. All right. So remember, also we have your chronic gastritis. Chronic gastritis is also attributable to an autoimmune in origin, wherein uh, there is usually involvement of the fundus. Okay? H. pylori, remember, there is predisposition to the antrum. Okay? So, tinatawag natin type A, yung autoimmune, and type B yung H. pylori. Doon muna tayo sa autoimmune. In autoimmune gastritis, it also involves the fundus and the body, and there is presence, take a look, presence of autoantibodies directed to parietal cell and intrinsic factor. Can you tell me, correlating to physiology, what will happen if there is no parietal cell and intrinsic factor? Okay, so if there is no parietal cell, hydrochloric acid production is reduced. So as a compensatory mechanism, because our body runs in compensation, there is hypergastrinemia. Hypergastrinemia. If the patient is having a lack of the intrinsic factor, remember intrinsic factor is very essential for the absorption of the extrinsic factor. The extrinsic factor, also known as your vitamin B12. Remember in physiology, these are absorbed in the terminal part of the ileum. If the patient fails to absorb vitamin B12, remember that B12, your cyanocobalamin, is important for DNA synthesis. So without the DNA, usually this patient will present with a megaloblastic pernicious type of anemia. Again, correlation. How can you differentiate a B9 from a B12 deficiency? Aside from the peripheral blood smear that shows megaloblasts, clinically, the differentiating factor is the presence of neurologic manifestation, which is irreversible with B9 deficiency. Again, pernicious anemia and gastric carcinoma, there is predilection to that with your autoimmune atrophic gastritis. And let's move on to the most important or the most common majority of your chronic gastritis is secondary to H. pylori infection. Mapapafuta ka na lang, futa. Yan, yun ang mnemonic, futa. This is a mnemonic. What are the different, what are the helping factors that will help this H. pylori to thrive? We have the flagella, of course, or flagella for locomotion. The urease production, of your urease production, the toxin, the CAG toxin produced by your H. pylori. So remember, H. pylori is a urease producing. It increases with age. It is associated with chronic gastritis and duodenal and gastric peptic ulcer and carcinoma. Do not forget carcinoma. You may want to add maltoma with H. pylori infection. So you see here in the slide, the most common cause of chronic gastritis, I want to give emphasis to this, H. pylori infection. The most common cause of diffuse atrophic gastritis is autoimmune, which is 10% of the time. The most common cause of chronic gastritis without H. pylori, autoimmune. Yun yung mga pearls no kailangan mo tandaan about chronic gastritis. Histologic findings, of course, kung makakita dito, no, makakita ng H. pylori, ano ang hanapin mo? Aside from the lymphocytes and plasma cells, because this is a chronic condition, you have to look for, again, histology. Neutrophils, bacteria, presence of bacteria, neutrophils. So you see lymphocyte and plasma cells with very scant, okay, neutrophil involvement, H. pylori infection. So what are the associated, again, paulit-ulit lang ako, dito naman, kinuha ko to kay Robbins, no? Poverty, household crowding, limited education, African American, birth outside the United States. Medyo racist siya. Pero yun yung sinabi ni Robbins, no? Birth outside the United States, that's a risk factor for H. pylori. Primary carrier, humans, mode of transmission, fecal oral route, pathogenesis. The most affected is the antrum. Remember that, antrum predilection. Or antrum predilection. So you see here what are the different disease associated. with hyperacidity, duodenal ulceration, antigenic stimulation. Of course, we have H. pylori. You are going to expect the immune system to respond. So there is a possibility of over-response, your monthoma, your B cell lymphoma, in atopic gastritis, your gastric adenocarcinoma, and of course, GERD, your H. pylori. So, shown in this image, we have your polar flagella, okay? The polar flagella, low-potrichous, di ba? Low-potrichous. So, sinabi na natin kanina, virulent factor niya, your cytotoxin, your CAG-A, and interleukin 8. Okay, of course, your urease. Yun yung, which enables this H. pylori to thrive to the acidic environment in the antrum. You have your urease production by H. pylori. Next, we have your autoimmune gastritis. Just to give emphasis on this, there's sparing of the antrum and associated with hypergastrinemia. Kasi nga, walang parietal cells, walang hydrochloric acid. Unlike doon sa H. pylori, wala namang hypergastrinemia, wala namang achlorhydria. Yun yung importance nila, no? Important differences. No? Antibodies to parietal cells. Doon sa H. pylori, antibodies to the H. pylori. Decrease serum pepsinogen 1 concentration. Mababa yung proteins. Endocrine cell hyperplasia, vitamin B12, and achlorhydria for autoimmune gastritis. So you see here, your autoimmune gastritis, the pathogenesis is simply loss of parietal cells. And the CD4 T cells are directed to the hydrogen potassium ATPase pump. There are diffuse mucosal damage affecting the oxyntic mucosal cell of the body and the fundus. Clinical manifestations lifted from Robbins, slow onset. Men are more affected. There's pernicious anemia. Other autoimmune diseases, Hashimoto's, type 1 DM, Addison, myasthenia, and Lambert-Eaton. Ano pinakaiba ng myasthenia? Graves and Lambert-Eaton. Ang myasthenia, kapag ginagamit yung muscle, doon siya nag-weaken. Sa Lambert-Eaton, habang ginagamit yung muscle, doon siya lumalakas. So just remember, just to give emphasis on the predilection of your H. pylori and your autoimmune gastritis, this image shows that H. pylori, we have antral predisposition, and your autoimmune, we have your diffuse in character. So you see here, from Medscape, just to create a pathophysiology, if there is lack of parietal cells, when destroyed, there is iron deficiency of anemia. B12 deficiency for pernicious anemia, and there is hypergastrinemia as a compensatory mechanism. So let's try to correlate with biochemistry and internal medicine. What are the neurological manifestations if there is B12 deficiency? What are the neurological manifestations? The first question is, what is the role of B12 in the central nervous system? Why do we present with nerve deficit, no? Neurodeficit when if you have B12 deficiency? Remember that vitamin B12 is essential for the fatty acid myelinization of the CNS. Again, what are the cells? For CNS, we have your oligodendrocytes. For the peripheral nervous system, we have your Schwann cells. And it is essential that we have myelin sheath for the saltatory conduction along the roads of Ranvier. Does it ring a bell? Yes. So can you tell me, if there is a deficit in the dorsal column, what is the manifestation of the patient? I believe you're going to answer that with B12 deficiency, the patient will present with impaired vibratory and position sensing. In the spinocerebellar tract, there is ataxia. In the lateral corticospinal tract, there is spasticity. Very nice. That's how you correlate it. Do not forget, with correlation to your B12, we have deoxyadenosylcobalamin and methylcobalamin, which are the active forms of B12 in human. And for therapeutic purpose, we have your cyanocobalamin and hydroxycobalamin. And very important to take note that B12 is from microbial and not from animals nor plants. Yes. So remember, just to correlate with biochemistry, we use around 3 to 5 micrograms per day of your vitamin B12. And it's nearly impossible for us to be depleted with this because we can store for as long as 5 years for B12 unless we have malabsorption syndrome. That's the importance of B12. So let's continue. Let's try to bridge peptic ulcer disease with uh, the physiology. So this image represents the oxyntic glands with the different cells located. We have here the isthmus, the neck, and the base. We have the fundus. You have the chief cells, the parietal cells, the mucous neck cells, and the surface mucous cells. And we have here in this image also we have the parietal cell undergoing transformation after secretagogue mediated stimulation. This images are lifted directly from Harrison's Principles of Internal Medicine. Excuse me. So, just a recap of what we have discussed earlier. We have the different components in providing the gastroduodenal mucosal defenses. Again, we have the unsteered layer of the mucus and bicarbonate. Here, we have the surface epithelial cells, which will secrete your bicarbonate, mucus production, prostaglandin, and again, the epithelialization of the mucosal progenitor cells and alkaline tide secondary to bicarbonate. Of course, very important to take note, we have the blood supply, also the sensory innervation, and here we have the prostaglandins. Just a recall of what you have learned in physiology, we have the vagus nerve, which serves as the main innervator of the gastrin. Remember the three important substances that are important for hydrochloric acid production. We have acetylcholine via vagus nerve stimulation. Also, we have gastrin and your histamine release. So dyan mag-act yung different kinds of medications also for histamine 2 blocker, working on the histamine 2 receptors. We have your proton pump inhibitors at the level of the basolateral membrane where it blocks the hydrogen potassium ATPase pump. So recall we have your peptic ulcer disease. Peptic ulcer disease, it affects mostly the distal stomach and proximal duodenum due to gastric secretions and impaired mucosa defenses. Again, increase in hydrochloric acid production, and there is a impairment of the defenses as we have earlier learned. We have chronic NSAID use and aspirin. Again, if you can recall, prostaglandins. Smoking, secondary to smoking, will cause decrease in blood flow, and H. pylori, of course, is a great player for PUD development. Okay, so the diagnosis is usually via endoscopy, imaging, and biopsy, looking for the main culprit of peptic ulcer disease. Commonly, the major location of your peptic ulcer disease are in the antrum and the first portion of the duodenum. All right, so the treatment, acid suppression, for example, we have your Santac, ranitidine, histamine 2 blockers, and of course, your most powerful medications, we use your proton pump inhibitors, eradication of the H. pylori infection. Does it ring a bell? If you can recall your OCAM regimen, we have your omeprazole, clarithromycin, azithromycin, sorry, not azithromycin, amoxicillin, metronidazole. And complications, we have bleeding, iron deficiency anemia following that bleeding, penetration to adjacent organs causing perforation, and of course, your pyloric obstruction. Do not forget the association of H. pylori Again, NSAIDs, smoking, increased gastric acid secretion, decrease in bicarbonate production. Another one, ectopic gastric mucosa, if you can recall in pathology, or with Meckel's diverticulum, GERD. Yes, you're correct. Esophageal ectopic gastric mucosa are also associated with peptic ulcer diseases. So remember, these are more common than the duodenal type. The most common is the duodenal type than the gastric ulcer. It is associated with H. pylori 100% most of the time. There's increased gastric secretion and rate of gastric emptying is also increased. Very nice to know that their blood group O is associated with peptic ulcer disease. And another disease entity, we have your MEN1 and Solinger-Ellison. Does it ring a bell? There is a gastrin-producing tumor. Cirrhosis and COPD are also associated with PUD. And commonly located, the most common location is uh, the anterior, sorry, we can use this one. The anterior wall of the proximal duodenum, that's the predilection of your peptic ulcer disease. Again, peptic ulcer disease in the stomach, 75% is associated H. pylori infection. Very favorite natin H. pylori na yan. Common location is the lesser curvature of the antrum. Usually, they present as solitary, small, less than 3 centimeters, and well-defined punch-out ulcer overhanging with radiating. You see here, the radiating mucosal folds. Oh, yun ang typical characteristic ng ulceration ng PUD. So do not forget, punch-out lesion with overhanging radiating mucosal folds. PUD. So most common complication again is bleeding followed by perforation and obstruction. All right. So in terms of epidemiology, you will see here the table, the different risk factors. We have H. pylori, of course, cigarette smoking, COPD, illicit drug use, NSAIDs, alcoholism, psychological stress, and the Solinger-Ellison together with viral infections. These are directly lifted from Katsu. Sorry, not Katsu, from Robbins. Increase in elderly, 60 above, with the use of NSAID. Of course, this patient will use the NSAIDs for the cardiovascular benefits being anti-platelet, anti-platelet, anti-thrombotic. Yes, that's the benefit of the baby dose of aspirin. With concurrent H. pylori infection, do not forget also the defense mechanisms, the mucin production of this elderly population is low. All right. So you see here the different characteristic of your PUD. You see here the puncture lesion and the necrotic debris, okay, the necrotic debris of your peptic ulcer disease. And these are the common manifestations. Again, bleeding, perforation, obstruction. So there is a classic peptic ulcer, round to oval, sharp punch out defect, acute gastric perforation. You see here the necrotic base of the ulcer composed of granulation tissue. Do not forget this, bleeding, perforation, and obstruction. These are the sequela of PUD complications. So you will see here the two most important comparison between the gastric ulcer and the duodenal ulcer. In terms of location, gastric ulcer is distal to the junction between the antrum and acid secretory mucosa, and most likely you will perform biopsy because of malignancy. So always do biopsy to rule out malignancy. Usual etiology, 75% H. pylori, NSAIDs. Okay, ironically, gastric ulcer, NSAID use together with NSAID use for both gastric ulcer and duodenal ulcer are risk factors. But according to Katsung, the chronic use of NSAIDs have Protective effect to colorectal carcinoma. That's the irony. Mamimili ka, meron kang bleeding secondary to PUD, or if you want protection for colorectal CA, that's the NSAID for you. So in the pathophysiology of gastric ulcer, there is gastric output that is normal or decrease. Again, do not forget, I just want to give emphasis on this. In terms of malignancy, this should be biopsied for GU. For duodenal ulcer, the first portion of the duodenum is commonly affected. Again, usual etiology, H. pylori and NSAID. And there's gastric acid secretion appears to be increased, and bicarbonate secretion is significantly reduced. Okay, in terms of symptomatology, because of the pain with food, nausea, and weight loss, there is burning or gnawing discomfort, okay, with gastric ulcer. And take note, this is worsened by food. So if it is worsened by food, do expect the patient will present with early satiety and weight loss. In comparison to the trivial, very trivial manifestation, that burning or gnawing pain of duodenal ulcer, that upon physical examination and history taking, you always ask, nagigising po ba kayo sa gabi sa gitna ng inyong pagtulog? That is the most discriminating feature of PUD in duodenal ulcer. And this is relieved by food, or relieved with food. Again, the most common complication is GI bleeding. Commonly, the patient will present with melena or coffee ground emesis. Okay, usually this gastric ulcer tends to penetrate the left hepatic lobe. Okay, in terms of perforation, okay, the duodenal ulcer tends to penetrate posteriorly into the pancreas. So you might think the possibility of pancreatitis. So what are the physical examinations? Physical examination that will be revealed in this bleeding patient, of course, with bleeding. Siyempre, pag nagkaroon ka ng bleeding as a compensatory mechanism, you will find tachycardia. There is orthostatic hypotension, and there is vomiting, there is dehydration secondary to vomiting or with bleeding. Kapag perforation naman, kapag may perforation yung patient, no, secondary to complication of your PUD, hahanap ka ng board-like rigidity. Board-like rigidity, the patient most likely will suffer from peritonitis. Gastric outlet obstruction, physical examination, succussion splash. Okay, retention of fluid in the stomach, that is suggestive of gastric outlet obstruction. So these are the comparisons between gastric ulcer and duodenal ulcer. So you see here, with advancing age, together with increased level of acid production, you will see with H. pylori, acute H. pylori infection, with time, chronicity, with chronic H. pylori infection, there is predominant antral gastritis that can lead to duodenal ulcer. Of course, do not forget that because of hyperimmune response, there is possibility of MOT, mucosa-associated lymphoid lymphoma, secondary to H. pylori infection. So do not forget also that in some cases, corpus predominant atrophic gastritis can lead to intestinal metaplasia. If you can recall, okay, your ballot esophagus in the distal third of the esophagus, gastric ulcer. In some spectrum of disease, we have your gastric carcinoma. So do not forget also that your arachidonic pathway, we have your prostaglandins. If you're going to disrupt the prostaglandin synthesis, you're already affecting the GI integrity, your platelet aggregation, and renal function. So you see here, these are the different factors affected with NSAID use. All right. So that's the pathogenesis of H. pylori and NSAIDs with PUD. Okay. This image just want to show you the regulation of the hydrochloric acid production. Just remember your vagus nerve. We have your acetylcholine, okay, working on the level of the hydrogen potassium ATPase, together with histamine coming from the enterochromaffin-like cells, okay, gastrin coming from the G cells that make calabet of the ACL that will elevate the level of this histamine, increase the level of your histamine. We have the ultimate stopper, the negative regulator produced by the D cell, your somatostatin, that will regulate the release of your histamine. And of course, we have your prostaglandins. So just remember, the effect of NSAIDs are both secondary to chemical trapping, excuse me, direct toxicity, iron trapping of the medication, and of course, to prostaglandin. Yun naman ang pinaka-topic natin for NSAIDs. Hydrochloric acid is increased, decreased mucin, bicarbonate, phospholipids, which all of which are protective to the surface mucosa. So that's it for H. pylori and NSAID. Let us try to have an imaging of the endoscopy found in gastric and duodenal ulcer. You will see here, this is a benign duodenal ulcer showing well-demarcated crater, often seen in bulb. You will see also in this image that there is a stricture with following a barium swallow. You will see also here the radiating mucosal folds, the benign gastric ulcer showing discrete crater with radiating mucosal folds, okay, originating from the peptic ulcer margin. So that's it for gastric and duodenal ulcers. Key points to ponder for acute and chronic gastritis. The spectrum of acute gastritis ranges from being asymptomatic to having the typical nausea, vomiting, and abdominal pain. Causative factors include any agent or disease that can interfere with the gastric mucosa, and acute gastritis can lead to acute gastric ulceration. And the most common cause of chronic gastritis, again, nandiyan na naman, H. pylori infection. And the most remaining causes are autoimmune gastritis. H. pylori is a predilection to the antrum and is associated with increased gastric acid production. The induced mucosa associated lymphoid tissue or multoma can transform to lymphoma. So dalawang cancer na, adenocarcinoma and lymphoma associated with H. pylori infection. So another one, kamukha ng kanina, autoimmune gastritis, atrophy of the gastric body oxytic glands. Kung may atrophy, compensatory mechanism G cell hyperplasia because of a response to your acroregia and vitamin B12. And again, antibodies are directed to your parietal cell and intrinsic factor, which are essential for B12 absorption. Intestinal metaplasia develops in both forms of chronic gastritis and is a risk factor for the development of gastric adenocarcinoma. Peptic ulcer disease, two key players, H. pylori and NSAIDs. Okay. So ulcers can develop in the stomach or duodenum and usually heal after suppression of gastric acid and eradication of H. pylori using your triple BMT regimen or quadruple OCAM regimen. So these are the neoplastic. Next, we have to discuss the neoplastic diseases of the stomach. We have your gastric carcinoma. So gastric carcinoma, risk factors involve dietary, smoked fish, mahilig ka ba kumain ng mga tinapa, mga barbecue, pickled vegetables, nitrosamines, benzpyrene, decreased fruits and vegetables. Another, nandiyan na naman, H. pylori, sinabi na natin kanina, chronic gastritis, blood type A. O kanina, ulceration, blood type O. Ngayon naman, gastric carcinoma associated epidemiology to blood type A. There is bacterial overgrowth in the stomach prior subtotal gastrectomy, and patients with menetrier disease. Usually, what is the presentation of the patient? Because of the fungating mass, okay, along in the course, the patient will present with weight loss and anorexia. Busog na eh, kasi mayroong mass, no? There's early satiety. It can mimic PUD, again, early satiety in this patient, and occult bleeding and iron deficiency anemia. Location, same with the earlier lesion, antral, lesser curvature. But the main difference, it is greater than 3 centimeters, irregular hip-up ulcer margin with necrotic base ulcers. Again, ano nga kanina sa benign gastric ulcer? Less than 3 centimeters, clean base, usually with clean with radiating folds coming from the ulcer. Sa malignant ulcer, walang radiating folds. Most common malignancy of the stomach, 90% is gastric adenocarcinoma. Early signs and symptoms of dyspepsia, dysphagia, and nausea. Again, there is attributable to lower socioeconomic groups and person with multifocal mucosal atrophy and intestinal metaplasia. In terms of pathogenesis, this is directly lifted from Robbins. In the diffuse type, there is mutation in the CDH1, loss of E-cadherin function, and intestinal type, the APC gene, or APC gene mutation. Remember the guardian of the cell, the TP53 mutations are present in majority of these gastric, both type of histologic gastric carcinomas. Gastric adenocarcinoma is associated with H. pylori gastritis, H. pylori-induced gastritis that will create further inflammatory mediators in the name of interleukin 1B and your tumor necrosis factor. Do not forget that another virus is associated with gastric adenocarcinoma, and we have your EBV, Epstein-Barr virus, that tends to occur proximal to the stomach with a diffuse morphology, with a marked lymphocyte, of course, lymphocytic infiltrate, okay, with EBV. So gastric adenocarcinoma, your intestinal type, develops from a precursor lesion. Usually it affects males in greater than female, males 55-year-old above, associated again with H. pylori, dietary factors, nitrosamines, okay, may mga salitre, no? Tobacco use, achlorrhea, and chronic gastritis. Just like the benign counterpart, it usually presents in the lesser curvature. Okay, in the lesser curvature. So you see here, this is your gastric adenocarcinoma with the hip-up ulcer, and the nest of malignant lesions, no? The nest of malignant lesions with adenocarcinoma. So let's talk about gastric adenocarcinoma diffuse type. Gastric adenocarcinoma diffuse type is not associated with H. pylori infection. There is diffuse infiltration of the stomach by poorly differentiated tumor, and I just need you to remember the signet ring cells, wherein mucin-filled cells with peripheral nuclei, there is displacement of the nuclei to the periphery. The stomach wall is grossly thickened. We have your linitis plastica. So remember this definition of terms. We have your Virchow nodes, which and your Krugenberg tumor, which both represent metastasis. Your Virchow node is manifestation of left. There's involvement of the left supraclavicular lymph node, and your Krugenberg tumor shows bilateral involvement of the ovaries. Diagnosis for this is endoscopy. Treatment includes gastrectomy, and prognosis shows poor overall 5-year survival rate of around 25%. You see here, this is the mucin-filled signet ring cell of gastric adenocarcinoma, histologically, you see here the signet ring cells recognized with their large cytoplasmic mucin filling the cell, displacing the periphery, showing as a signet ring, no signet ring appearance. In this figure, gross appearance of diffuse adenocarcinoma, we have your linitis plastica, your leather bottle appearance. The gastric wall is markedly thickened. You see also there is loss of rugal folds. No? This is your leather bottle appearance, linitis plastica, and the signet ring cells of diffuse type of gastric adenocarcinoma. The most common location of your gastric adenocarcinoma with your lymphoma is the GI tract. That is according to Robbins. Most frequently, it is associated with Epstein-Barr virus B cell proliferation, and nearly 5% of the gastric malignancies are primary lymphomas that can manifest with mucose-associated lymphoma or lymphoma. The most common location is extranodal marginal zone B cell lymphomas, followed by diffuse large B cell lymphoma. So you see here, this is the diagnostic lymphoepithelial lesions. You see here the dense lymphocytic infiltration in the lamina propria. You see here in disseminated lymphomas within the small intestine, you will see numerous numbers of nodules, no? Numbers of nodules along the small intestine, and you see here wall infiltration of the large B cell lymphoma affecting the walls, causing diffuse thickening. So gastric adenocarcinoma, we have the least minority, we have here lymphoma. The most common, again, extranodal lymphomas in the gastrointestinal tract. The most common location is the stomach. The most frequent site for your Epstein-Barr virus. You see the common manifestation of dyspepsia, eructation, epigastric pain, and some hematemesis, melena, and weight loss. Carcinoid tumor is a well-differentiated neuroendocrine tumor, carcinoma-like carcinoid, and most are found in the GIT tract. Commonly, majority for greater than 40% are found in the small intestine. Next common site is the tracheobronchial tree. Tama yun, tama no? Gastric carcinoid tumors can be associated with endocrine cell hyperplasia, autoimmune chronic atrophic gastritis, if you can remember, your MEN1 syndrome, your Solinger-Ellison syndrome, and in terms of predisposition, it peaks at around the sixth decade of life, but may appear any time or any age of the patient. Symptoms are determined by the hormones being produced. Most important prognostic factor is the location. The foregut, you resect. No, we resect that portion in the midgut. Often they present with multiple lesion and they are apparently aggressive. In the hindgut, they are typically discovered incidentally. Look at this image lifted from Robbins. You will see here the tumor has spread extensively within the mucosa. Okay, in the mucosa, there's a tumor expansion. Of course, also this you see here the tumor also with the carcinoid tumor presents with a large mass and intense enterochromaffin-like cells yung presentation ng mga carcinoid tumor. So in this image, you will see there's extensive proliferation across the mucosal lymphatic channels, and electron microscopy reveals cytoplasmic dense cytoplasmic dense neurosecretory granules of the carcinoid tumor. So in this figure, you will see the common location of the carcinoid tumor. All right. So next pathology is gastrointestinal stromal tumor that you have already encountered in surgery. This is the most common mesenchymal tumor of the abdomen, wherein more than 50% arises in the stomach, more commonly affecting the male population greater than 60-year-old. The pathogenesis, 75 to 80% have oncogene gain of function mutation. Take note of the tyrosine kinase c-kit. That is the clue for this. The tyrosine kinase c-kit. They share as a common stem cell with the interstitial cells of Cajal. Remember, this is a pacemaker of the gut, your interstitial cells of Cajal. So you will see here the gross appearance of your gastrointestinal stromal tumor. Usually they present large enough, usually 30 centimeters, solitary, well circumscribed. This is a world appearance, fleshy mass covered by uh, an intact mass. Usually, sometimes they also present as ulcerated. In this image, you will see that this is projected outward the serosa. So that is gastrointestinal stromal tumor, the most common mesenchymal tumor. In this figure, you will see the nest of world pattern appearance of your gastrointestinal stromal tumor. The most useful diagnostic feature is the kit, and the diagnostic and the treatment for gastrointestinal stromal tumor, if you have encountered already in surgery, that's your imatinib or your Gleevec. Your Gleevec, the brand name of imatinib, that's the medication we use in the management of GIST. Actually, GIST, I've learned in our surgery discussion, has a poor prognosis. No, signs and symptoms are similar to the mass effects, and with blood loss, patient may present with anemia. Now let's proceed to the diseases of the small bowel, your small intestine. We have your irritable bowel syndrome, Crohn's disease, ulcerative colitis. These are letter B and letter C are your inflammatory bowel disorders. Let's start with this question. A 32-year-old woman presents to the physician with alternating bowel movement, diarrhea, constipation. She also presents with chronic abdominal pain, relieved by frequent bowel movement, and exacerbated by stress. The patient denies fever or weight loss. She has a negative hemoccult test and colonoscopy shows and endoscopy shows no abnormalities. No abnormality. These are the clues. The most probable diagnosis in this patient is commonly associated with which of the following? So this is a two-step question. First, you have to identify what's the diagnosis, followed by what is the expected finding in the patient's diagnosis. So what's the answer for this? So there is an alternating bowel movement, okay, with no organic cause. There's no pathology being seen. That is your irritable bowel syndrome, and normally it will present with a normal biopsy. And a biopsy in irritable bowel syndrome, if you can recall in pathology, it shows normal structures. If you can recall, irritable bowel syndrome is a functional gastrointestinal disorder characterized by abdominal pain and altered bowel habits in the absence of an organic cause. A common patient will present with diarrhea, followed by constipation, chronic abdominal pain, tapos nawawala yung pain kapag nadudumi. And sometimes your stress, your onset, the stress affects the onset of the presentation. For example, emotional stress, okay, it can affect, no, it can affect the presentation of the irritable bowel syndrome. Letter A, I think that letter A, if we're going to give a differential for this in terms of this condition, pseudomembranous colitis is most likely will present with leukocytosis, and usually they present with the use of broad spectrum antibiotics wherein it will promote an overgrowth of your Clostridium difficile. Primary sclerosing cholangitis is an extraintestinal manifestation of irritable bowel disease. Most commonly, primary sclerosing cholangitis is associated with ulcerative colitis. We will discuss that later. Strictures in the small bowel. Commonly, we have your Crohn's disease. You have the skip lesions and are generally evident on colonoscopy, endoscopy, or radiography. Venous flattening, that is associated with malabsorption syndrome, for example, celiac sprue, wherein there is malabsorption of malabsorption. It presents with bulky fat stools following meals. Endoscopic findings will include venous flattening in the small intestine. So the answer for this is irritable bowel syndrome, which shows normal presentation. Again, irritable bowel syndrome, it presents with recurrent abdominal pain that is related to defecation, change in stool frequency, change in form and consistency. And take note, there is no structural, take note of this, that's the main differentiating factor. This is actually a diagnosis of exclusion. There is no structural abnormality. Most commonly affecting middle-aged women, chronic symptoms may be diarrhea predominant, followed by constipation predominant or mixed. Pathophysiology is multifaceted, and the first line management for this is lifestyle modification, primarily diet modification. Let's go to your inflammatory bowel disorders. Inflammatory bowel disorders, both are common in young women. Both, I mean, your Crohn's disease, inflammatory bowel disorders, or Crohn's disease and ulcerative colitis. Most commonly affecting whites, 3 to 5 times more common in Ashkenazi Jews. And we have potentiated the hygiene hypothesis. The hygiene hypothesis suggests that there is changes in incidence of food preparation nowadays, that yung katawan natin, no, yung dating normal na napapresent sa maraming bacteria ngayon, dahil sa hygiene hypothesis sinasabi na pag sobrang malinis yung preparation, wala ng lakas yung immune response. Parang sa asthma, no? Yung asthma may hygiene hypothesis. Sinasabi na kung sino yung mas madalas na expose sa madumi, naging expose sa mga bacteria, sila yung may immune response at may immunity. Okay. Simple lang. That is your hygiene hypothesis. But in theory, your inflammatory bowel disorder, there is an interaction between the host, of course, the human, the intestinal microbiota, the intestinal epithelial dysfunction, and again, the immune response. That's a pathogenesis of your IBD. So this table lifted from Robbins will show the difference between Crohn's disease and ulcerative colitis. You will see here, first in Crohn's disease, let us try to remember that the keyword you should remember here, you have skip lesions, you have skipping lesions in Crohn's disease. Inflammation, in terms of depth, transmural, yung ating Crohn's disease. Actually, in clinical manifestations, both Crohn's disease and ulcerative colitis almost always the same, both intestinal and extraintestinal. Nagkakaiba lang sila sa areas being affected, no? Again, skip lesions, Crohn's disease. Ulcerative colitis, continuous colonic involvement. Beginning in the rectum, proximal yung kanyang presentation. Proximal yung ulcerative colitis. Sa lalim, transmural. Yung Crohn's disease, mas malalim, no? Yung ulcerative colitis naman, limited lang sa mucosa and submucosa. Okay, so let's move further for the comparison of the two. So the model of pathogenesis of inflammatory bowel disease, there is combination of interaction of the host, intestinal microbiota, epithelial dysfunction. One of these models that will unify this is this model, wherein the intestinal microbiota, epithelial function, mucosal immunity will suggest a component that will activate the innate and adaptive immune response. So usually in a genetically susceptible host, the subsequent release of the tumor necrosis factor and other immune-mediated response will direct signal to the epithelia to increase the tight junction permeability. Kung ang tight junction permeability ay mas mataas, mas marami magkakaroon ng flux ng microorganism going deeper, no, from the luminal side going to the cellular side. These events will establish self-amplifying cycles, paulit-ulit lang yan, in a stimulus wherein the patient sufficient enough to initiate an inflammatory bowel disorder. Okay, that's the model of pathogenesis of inflammatory bowel disease. In Crohn's disease, usually it begins with an aphthous ulcer. The most common site, take note, is the terminal ileum and the cecum, and multiple separate and sharply demarcated lesions. We have the skip lesions. Again, the earliest lesion, usually the aphthous ulcer that appears, they coalesce and they appear serpentine-like along the axis of the GI, the gastrointestinal tract being involved. Cobblestone, this is the key word. Cobblestone appearance. Fissures, creeping fat necrosis. Mamaya, creeping fat necrosis and creep abscesses. So makikita natin yan. Okay. And this figure, you will see here, left intestinal, in the left figure, you see small intestinal strictures. Small intestinal strictures. You will see here your cobblestone appearance. Yung cobblestone appearance na yan, the depressed area, usually these are the areas that are abnormal. So nagkakaroon ng cobblestone appearance in Crohn's disease. This is the creeping fat necrosis. The creeping fat necrosis secondary to transmural edema, inflammation, fibrosis, and hypertrophy of the muscularis mucosa. This imaging will show the anteroposterior radiograph of early stage of enterocolitis, wherein you will see the long arrow represents the string sign. Further luminal distension, okay? On this image, you will see the further luminal distension. Further luminal distension overcomes spasm. So you will see here both radiographically and morphological presentation of Crohn's disease. Signs and symptoms, intermittent attacks of relatively mild diarrhea, fever, abdominal pain, rash, eye inflammation, oral ulcer, arthritis, calcium oxalate kidney stone. This figure is lifted from, I think I lifted from a nursing site. You will see the spectrum of signs and symptoms of Crohn's disease together with the factors associated with this. So that's your Crohn's disease. Again, you will see malabsorption, malnutrition because of the repeated cycles of inflammation. There is malabsorption and malnutrition. Take note, there is a possibility or predilection to colorectal cancer and fistula formation. Treatment will include steroids, azathioprine, that is, azathioprine is a purine analog inserted in the DNA will cause chain termination, ciprofloxacin, a fluoroquinolone, metronidazole, we have your monoclonal antibody infliximab and adalimumab. You will see here the haphazard organization of the creep repeated secondary from a repeated injury and regeneration. You will see here the non-cascading granuloma formation and represented by the arrow, we have the transmural Crohn disease with some mucosal and serosal involvement. Commonly associated disease, we have pyoderma gangrenosum, erythema nodosum, episcleritis, and uveitis, followed by uveitis. Yes, uveitis. Ulcerative colitis presents with the same manifestations, clinical manifestation, just like your Crohn's disease. However, they differ in the areas being involved. In ulcerative colitis, it is limited only to the rectum and extends proximally. Take note there is no skip lesions nor granuloma. Inflammation is limited alone to mucosa. Take note of that. One of the major differences and superficial submucosa. Presence of pseudopolyps, there is no granuloma, there is no mural thickening. So this slide represents the differences with your Crohn's disease. That's your ulcerative colitis. Again, ulcerative colitis will only involve the mucosa and submucosa. Okay, mucosa can regenerate, creating a pseudopolyp. I will show it later, presence of pseudopolyp formation. So you will see here, this is the gross appearance of your ulcerative colitis. You will also take note in this image that this separates the normal from the abnormal portion of the colon. So with repeated injury, and for regeneration, injury, there is formation of a pseudopolyp. Remember, what is a true polyp? What is a characteristic of a true polyp? A true polyp is a lesion that grows above the epithelial layer. And this is not. This is a pseudopolyp. So in a nutshell, this table represents the major comparison between your Crohn's disease and ulcerative colitis. Take note, the most common site for Crohn's disease is terminal ileum. In the ulcerative colitis, we have the rectum. Distribution of Crohn's disease, mouth to anus. From mouth to anus, that's mouth to anus. From ulcerative colitis, we have rectum to colon. So that's proximal in distribution. There is discontinuity with Crohn's disease. There is skip lesion. Sa ulcerative colitis, walang skip lesion. Continuous yan. Gross features. Commonly, your Crohn's disease presents with aphthous ulcer with intervening normal mucosa, abnormal, kaya nagkakaroon ng cobblestone appearance. There's thickening of the bowel wall and creeping fat. In your ulcerative colitis, there is pseudopolyp formation and creep abscesses. So again, very important to take note, transmural Crohn's disease. Ang ulcerative colitis, mucosa and submucosa alone. Complications, Crohn's disease, strictures, string sign on barium enema, obstruction, abscess formation, fistula, sinus tract, toxic megacolon for ulcerative colitis. Take note, genetic association, HLA B27 for ulcerative colitis. That's the genetic association. Extraintestinal signs and symptoms, though uncommon, both Crohn And your ulcerative colitis can present with the extraintestinal manifestation. And with ulcerative colitis, there is a higher risk of malignancy. So let's continue the discussion for gastrointestinal microbiology. So this question, a woman from Talipapa comes to you because of profuse watery diarrhea, non-bloody diarrhea that developed 5 hours after she had eaten tuna salad. She is diagnosed with food poisoning. Which of the following is a characteristic of the most likely cause of her symptom? So one of the features that we're going to discuss are the features of diarrhea. So what are the different causative agents that can cause diarrheal diseases? Letter A, microscopic examination of the patient's stool will demonstrate gram-positive, catalase-positive, and coagulase-negative bacteria. So most likely, we're talking about the Staphylococcus epidermidis and Staphylococcus saprophyticus, which are associated with urinary tract infections found in indwelling devices or your catheters, respectively. Regardless, the organism would not likely be present in the stool as this is a toxin-mediated reaction. Letter B, positive Quillang reaction in the culture. Can you think of what are the different pathogens that will manifest with positive Quillang reaction? You're going to think of encapsulated bacteria only. For example, we have your Streptococcus pneumoniae or Neisseria meningitidis. Martin media could be used to culture the pathologic organism from this patient's stool if we're talking about uh, Neisseria gonorrhea. Letter D, contaminated canned fish was the source of the pathologic organism, or is it letter E, enterotoxin, which comes from a preformed in the food, therefore there is a short incubation time for the development of the disease? The correct answer is letter D. All right, let's continue our discussion. So these are the different characteristics of viral and bacterial agents that can cause gastroenteritis lifted from Harrison's Principles of Internal Medicine. So let's look at some important comparison between viral gastroenteritis compared to gastroenteritis secondary from bacterial in origin. So we have viral gastroenteritis. Usually, there is a low infectious dose, around 10 to 100 viral particles for most of the agents. And for bacterial gastroenteritis, there is high infectious dose to cause diarrhea. For example, E. coli, Salmonella, Vibrio, Shigella requires a low dose infectious dose to create diarrhea. So in terms of incubation period, most likely viral gastroenteritis will show 1 to 3 days for most agents, or sometimes can be shorter, for example, your norovirus. For bacterial gastroenteritis, Campylobacter jejuni, E. coli, Shigella, Salmonella will present with an incubation period of around 1 to 7 days. Primary reservoir for viral gastroenteritis, primarily we have humans. And for bacterial gastroenteritis, it depends on the bacterial species. In terms of diagnosis, just look at this. This is for viral gastroenteritis. Commonly, we use in clinical practice, clinical history, followed by different ancillary procedures. For bacterial gastroenteritis, fecal examination for leukocytes and presence of blood in cases of dysentery are useful in the diagnosis of bacterial gastroenteritis. In terms of management, because viral gastroenteritis are self-limiting, perhaps the management would be supportive. And antibiotics and antimotility agents are usually contraindicated in these cases. First, for bacterial gastroenteritis, of course, you have to provide supportive nutrition, hydration, and most likely antibiotics will be recommended in the management of dysentery, for example, your Shigella or diarrhea caused by Vibrio cholera, in order to decrease or shorten the duration of the disease process. So let's discuss some of your bacterial enterocolitides. The most commonly it is associated with the pathogens are varying with age, the nutritional status of the patient. For example, we have your pediatric diarrhea. Most commonly, it will result from dehydration and metabolic acidosis. If you are going to consider the total body surface or the total body water component of the pediatric population. Environmental influences will include epidemics in consideration, for example, for cholera, poor sanitation, of course, inadequate public health measures, or as a consequence of natural diseases. So that's for bacterial enterocolitis. After the recent earthquake in Central America, okay, there's a development of acute onset of watery diarrhea. Lumabas yung sagot. For the past 12 hours, averaging one episode per hour. Physical examination, you will see flecks of mucus in the stool, sunken eyes, dry mucous membranes, and decreased skin turgor. Patient is febrile, and it shows with a blood pressure of 90/60 and tachycardic at around 110 beats per minute. Most likely, the answer to this is Vibrio cholera because of the severe watery diarrhea and physical examination. Very important to take note of the degree of dehydration of the patient. Is the patient suffering from acute gastroenteritis with no dehydration, mild dehydration, or severe dehydration? It depends, of course, in the vital sign of the patient. So with this patient, most likely, the patient is suffering from moderate to severe type of dehydration. So the causative agent is Vibrio cholera. So this figure lifted from Robbins' pathology, you will see the different microorganisms that we're going to tackle in cases of bacterial enterocolitis. So it is uh, very important to discuss your cholera. Your cholera, usually the reservoir comes from shellfish, and the mode of transmission is fecal oral. And affected GI sites usually is the small intestine. And again, I've mentioned earlier, severe watery diarrhea is the prominent symptom. So complications will include dehydration, electrolyte imbalance. So very important to check for the level of hydration of the patient. Next, we will discuss further Campylobacter jejuni infection, which is the most common bacterial infection causing diarrhea. Usually, the main reservoir, we have your chickens or poultry, your sheep, pigs, and cattle. And the mode of transmission is through ingestion of food infected with Campylobacter. Signs and symptoms will include watery or bloody diarrhea. There are also associated diseases, for example, your Guillain-Barré syndrome, your ascending paralysis, and arthritis, some of which are associated with reactive arthritis. So again, it is very important in this table to take note of the infection type, the reservoir, mode of transmission, symptomatology, and complications. And of course, we're going to discuss some of the treatment. Shigellosis, your Shigella. Shigella, the main reservoir is humans. Again, the mode of transmission is fecal oral. Commonly, it affects the GI tract, the left colon, and the ileum. It will present with dysentery. Dysentery is described as diarrhea with a bloody diarrhea. So associated diseases, we have reactive arthritis, your hemolytic uremic syndrome, your HUS. We'll also discuss our salmonellosis associated with a reservoir from poultry farm animals or reptiles, but the most common mode of transmission is ingestion of contaminated poultry products. Symptoms can manifest with watery or bloody diarrhea, and sepsis can ensue further. Your typhoid fever, if you're familiar with your Salmonella typhosa, the only reservoir is humans. Fecal oral water transmission is very important, and it will present as well with bloody diarrhea. Chronic infection can lead to carrier state, encephalopathy, or myocarditis. We will discuss further this EHEC, ETEC, AEC, and your enteroaggregative type of your E. coli. Your pseudomembranous colitis also will be discussed in this lecture. So, One of the most important bacterium that is associated gas with gas with diarrhea is Vibrio cholera. So it is very important in microbiology to study the morphology of the pathogen. In this case, we're going to describe the morphology and biochemical properties of the pathogen. Your Vibrio cholera is a gram-negative flagellated, take note, it is a comma-shaped, oxidase positive. It grows in alkaline media. It's a gram-negative microorganism that is endemic to developing countries or endemic to developing countries. The main problem with Vibrio cholera is the characteristic watery diarrhea, which is very severe in nature. Usually, it can manifest with around 1 liter per hour of diarrhea that is characterized as flaky mucoid, and the complication is severe dehydration for Vibrio cholera. The main pathophysiology for this is increasing level of your cyclic AMP. The enterotoxin coming from the Vibrio cholera will activate permanently the CFTR gene. The CFTR gene that will cause an efflux of the chloride ion, wherein together with the chloride ion, it will attract other ions. For example, the sodium. Remember in physiology, where sodium goes, water follows. It will cause diarrhea. No, that is the pathophysiology of your Vibrio cholera. So it is very important in the study of microbiology to also take note of the different culture medium. So we're going to discuss the medically important Vibrios. We have your Vibrio cholerae 010139, which is associated with epidemic and pandemic cholera. Your non 0139 choleras is associated with cholera-like diarrhea. Vibrio parahemolyticus, does it ring a bell? You're going to think of shellfish. It is associated with gastroenteritis, perhaps sometimes associated with extraintestinal infections. So you see here, this is your TCBS agar. The TCBS agar, you see the yellow colonies of the Vibrio cholera. The yellow colonies. So very important to take note of the different agars used in growing microorganisms. Or in this case, your TCBS agar for Vibrio. Again, this is peculiar to your Vibrio cholera. You will see the mucoid flaky diarrhea, which is severe in nature. Remember that Vibrio cholera is non-invasive and it will remain in the luminal area. Again, I have mentioned earlier, it is secondary to the preformed enterotoxin that will cause GS stimulation that will open the CFTR channel that will release further chloride together with some ions that will cause accumulation of sodium and bicarbonate causing secretory diarrhea. So the problem of the patient, because we're throwing up too much of the bicarbonate, is severe dehydration with associated metabolic acidosis. So remember also that in the management of Vibrio cholera, one of the antibiotics that you can give is your oral tetracycline and doxycycline that will reduce the output in cholera and will shorten the period of excretion of the Vibrio. In some cases wherein the management of Vibrio cholera with tetracycline becomes resistance, the genes are, because they are transmissible, there's a possibility of mutation through plasmid mediated. Sometimes the alternative medication, in some situation for children or pregnant women, we can include alternatives to tetracyclines will include the use of your macrolide. A very good example is erythromycin. So again, one of the important management of Vibrio cholera is to assess the degree of dehydration and to take note of this degree of dehydration. For example, you will see here if there is none or mild diarrhea, usual manifestation, the patient will present with thirst. With moderate diarrhea, you need to assess the vital signs of the patient. If there's already tachycardia, decreased skin turgor, postural hypotension, doon na pumapasok yung moderate degree of dehydration. If the patient presents with unconsciousness, lethargy, floppiness, or weak or absent pulse, and of course, very important to take note in children, the fontanelle, especially in infants, if it is sunken, it will give a clinical picture of the level of hydration of the patient, and of course, inability to drink, if there is convulsion, of uh, the danger signs of acute gastroenteritis. You will see here that the main treatment for Vibrio cholera is to replace fluids with oral rehydration solution if the patient, of course, can tolerate the oral route. Otherwise, you have to provide aggressive management through intravenous fluid resuscitation. So that's Vibrio cholera. Okay. Another pathogen of importance is your Campylobacter jejuni. Campylobacter jejuni is mostly associated with traveler. The main mode of transmission is through fecal oral route, person to person, or via ingestion of undercooked, contaminated poultry or meat. In the usual scenario, chickens and pasteurized milk. Take note, it is a gram negative. It appears as a gull wing, gram negative, comma or S shape. Take note of the temperature. It grows well with 42 degrees centigrade, and it is the major cause of bloody diarrhea, especially in children. Again, the mode of transmission, one of the most important things that you have to remember when you're talking about diarrheal diseases, the mode of transmission, the type of pathogens, and the culture media. So you see here in Campylobacter jejuni, we have four virulence factors. What does it mean? We're talking about the factors that will cause further the disease. The motility is secondary to the flagella. It is flagellated. It allows the Campylobacter to move. The adherence, the toxin production, we have the cytotoxin that will cause epithelial damage, and a cholera toxin like enterotoxin that will be associated with Campylobacter jejuni. In some cases, Campylobacter jejuni can also lead to dysentery. Generally, it is associated with invasion and only occurs in a small minority of patients infected with Campylobacter jejuni. Enteric fever, when of course the bacteria proliferates within the lamina propria and the mesenteric lymph nodes, there is a possibility of enteric fever. No, you're going to think of salmonella infection with enteric fever. Of course, reactive arthritis, these are extra-intestinal manifestation, other associated diseases, erythema nodosum, and Guillain-Barré syndrome. Guillain-Barré syndrome, I've already encountered this patient wherein the patient, if I can fairly remember, a pediatric patient that came to the ER because of ascending. Uh, Initially, the patient presents with weakness. No, ang naging diagnosis ko noon is acute gastroenteritis with mild dehydration. When afterwards, after several hours, the patient presents with difficulty of walking, cannot cannot move both limbs, and apparently after a week, I saw the patient already uh, in mechanical ventilator. The diagnosis was Guillain-Barré syndrome. This is ascending type of paralysis. So very rare, pero makikita nyo yan sa clinics, no? Perhaps, no? Makikita nyo yan, ma-appreciate itong Guillain-Barré syndrome. Okay. So remember, reactive arthritis, especially it is associated with their age. Sorry, I write it. HLA, does it ring a bell? HLA-B27, associated with HLA-B27 gene, that is your reactive arthritis. And this histology, you will see here that all of these acute self-limited colitis, you will see predominance of neutrophils, and presence of crypt abscesses, crypt epithelium and crypt abscesses here in this lower right figure. Predominance of the neutrophils, but you will see there is an intact mucosal lining even though there is crypt abscesses. So for Campylobacter jejuni infection. And the mode of treatment is fluid and electrolyte replacement. Indication for treatment if there's high-grade fever, bloody diarrhea, severe diarrhea persistence for greater than a week, or worsening of signs and symptoms. Kung kanina, no, Vibrio cholera, if you're going to use oral tetracyclines to shorten the duration of the disease. The use of antibiotics also is recommended for treatment. Use of anti-motility agents can cause prolongation or the duration of symptoms and had been associated with toxic megacolon, and the use of this is not recommended for Campylobacter jejuni. So usually the mode of treatment, okay, a 3-day management of azithromycin 500 milligram once daily, or you can give fluoroquinolones, ciprofloxacin as an antibiotic given TID, or levofloxacin 750 milligram daily for 3 days for Campylobacter jejuni infection. Next pathogen is Shigella. Shigella is a gram-negative important member of the Enterobacteriaceae. Remember, they are non-lactose fermenters and they appear colorless on your McConkey agar. Take note, Shigella is non-motile compared to Salmonella, which is motile. Shigella of medical importance, the most common in the United States is Shigella sonnei, and we're going to discuss here your Shigella dysentery causing bloody diarrhea. Shigella dysentery is considered the most severe and the most common in developing countries. Okay. Shigellosis, again, gram-negative rods. They appeared encapsulated. They are non-motile, facultative anaerobes. The only reservoir, humans. Mode of transmission, fecal oral route. And take note of this. Shigellosis, we only need at least less than 100 to cause disease. Very low infective dose for shigellosis. Again, shigellosis, the infective dose is lower than 100 microorganisms, and each gram of stool may contain more than expected during the acute phase of the disease. Shigella is one of the top 4 pathogens associated with moderate to severe diarrhea and is now ranked first among 12 to 59 months of age. So shigellosis, again, the distinguishing characteristic, remember, they are non-motile and it is identified by biochemical reaction. Take note, they are invasive. They are invasive. Endotoxin will trigger the inflammation. Take note, they are invasive in nature. They will invade the M cells, which will produce a very shallow ulcers, and rarely it will cause invasion of the blood vessels. So when you're thinking of Shigella, commonly associated you're going to think of Shigella, you're going to think of the Shiga toxins. The Shiga toxins will cause inactivation of the 60 ribosome by removing adenine. What are the complications? We have your hemolytic uremic syndrome that is similar to enterohemorrhagic type of your E. coli. Or if you can remember your HUS, what are the triad of your HUS? We have thrombocytopenia, microangiopathic type of anemia, and AKI. Again, hemolytic uremic syndrome can present with the triad of microangiopathic hemolytic anemia, renal failure, acute kidney injury, and thrombocytopenia. What's the pathogenesis of your Shigella? Your Shigella will be engulfed by, it has a tropism to your M cells. No? Upon tropism with the M cell, lilipat siya sa ibang enterocytes. Lilipat siya sa iba. Doon siya nagkakaroon ng pagkakataon tumakas, tinatakasan niya yung immune system, pupunta siya sa ibang part, okay? Ibang part, sa ibang cells, no? Cell to cell yung kanyang paglipat. So invasion strategies is an invasion strategy for Shigella. Again, it is through M cell. The uh, M cell is a M cell is abundant, no? Shigella will invade the M cell, and you will see in this figure, pagkapasok niya sa M cell, papunta sa ibang cell, pupunta siya sa ibang part, magre-replicate sa ibang cell, no? Wala nang balikan sa extracellular environment. Okay. Shigella species. We have your Shiga toxin. This Shiga toxin will inactivate again your 60 ribosome. 60 ribosome by removing your adenine from your RNA. Again, associated with hemolytic uremic syndrome and dysentery. This Shiga toxin is produced primarily by your Shigella dysentery type 1. So we have the Shiga toxin. Again, it is an invasive type of pathogen. So again, for clinical correlation, typically your hemolytic uremic syndrome in children is associated or accompanied with diarrhea caused by Shiga-like toxin. Another one, the Shiga-like toxin, which is kasama nun ng EHEC, no? So EHEC, both the EHEC and the Shigella, pareho silang merong hemolytic uremic syndrome. So you will see here the patient will present with a severe form of dysentery, enterocolitis, and shigellosis. If you will appreciate this image lifted from osmosis, again, the main pathogenesis of your Shigella is to invade the M cells. Once they are inside the M cells, they are capable of escaping the immune system. They will infect through the paracellular pathway other cells through actin jet polymerization. So you will see here signs and symptoms of dysentery. Usually, the patient will present with low-grade fever, lower abdominal cramps, tenesmus, diarrhea. Usually, they always present first with watery, followed by a bloody diarrhea. That's a common scenario for Shigella. Remember, they are invasive, but rarely can cause septicemia and shallow ulcer. So that's shigellosis. Again, the mode of transmission is fecal to oral route. So these are the recommended management for Shigella species. I mentioned this earlier. We have ciprofloxacin and fluoroquinolones. We have ceftriaxone, azithromycin as an alternative medication. So the drug of choice is your ciprofloxacin. So the management, aside from the antibiotics, of course, is to give hydration through fluid and electrolyte replacement, and of course, for promotive and preventive management is through proper sanitation. A teenager male presents with urinary tract infection and you suspect E. coli infection. What is the gold standard? So the gold standard for most of the pathogen is to get the culture. So in particular, in this case, is culture on the EMB agar for E. coli. E. coli is a gram-negative rod. It ferments lactose. It is a facultative anaerobic oxidase negative. It is a lactose fermenter and colonies with iridescent green sheen on the EMB. Take note that the reservoir, human colon, and may colonize the vagina and urethra, causing, of course, the most common cause of urinary tract infection is E. coli. Contaminated crops are also a source of your E. coli, and enterohemorrhagic strains from bovine species. Take note of the virulence factor. Of course, you will note your fimbriae. Your fimbriae, medyo pangat ng sulat, no? Your fimbriae will cause attachment. So, in urinary tract infection, it is associated with cystitis, in some cases, pyelonephritis. The K capsule, if you can recall from microbio, the K capsule of the This is extraintestinal distortion for E. coli. The K capsule is important for the pneumonia, neonatal meningitis, and of course your LPS, all of the gram-negative microorganisms with LPS, your endotoxin, that is associated with septic shock. Diba? They have LPS or lipopolysaccharide. So gastroenteritis is the point of discussion here for E. coli, and we have enterotoxigenic E. coli. The mnemonic here is T, ETEC. So it is mostly associated with travelers. In terms of epidemiology, nabanggit lang ni Robbins, Mexico, in Mexico, in Mexico, drinking water. Okay. So, pag napunta ka daw ng Mexico, dapat wag kang umiinom basta-basta kung saan-saan. Munti ka ng bottled water kasi the E. coli can present with voluminous type of diarrhea. This is the major cause of travelers' diarrhea and diarrhea in less than 3-year-old in developing country. I have mentioned a great example is Mexico. Two enterotoxins are associated. We have your heat labile toxin, which is your LT, and your heat stable toxin, which is your ST. Your LT toxin mimics the Vibrio cholera. Does it ring a bell? It mimics the Vibrio cholera, increasing the ribosylation of your increasing level of your camp. So you will see here increased chloride ions that can lead to secretory diarrhea. Your ST will stimulate, this is the ST that will stimulate the guanylate cyclase that can cause further diarrhea. Take note of the other factors, your capsule and your colonizing factor adhesins. Or ETEC. Again, ETEC, mnemonic, ETEC, ET, travelers, diarrhea. The mainstay treatment for E. coli is, of course, hydration. But if you want to shorten the duration, you can give your TMP-SMX. Cotrimoxazole is a bactericidal medication. TMP alone, static. SMX alone, static. If you're going to combine them, you're going to create a bactericidal antibiotic. Another important E. coli is your EPEC. EPEC, enteropathogenic, second most common cause of infantile diarrhea because the most common is rotavirus. EPEC stands for pneumonic, P stands for pediatric for babies less than 1 year, and they can cause prolonged diarrhea in pediatric population. So the main factor for here is the E. coli adherence factor that will bind again to your M cells that will cause rearrangement of the actin and cause effacement of the brush border of the microvilli. So what will happen if there is effacement of the microvilli? Is there absorption? Of course, none. So most likely the patient will present with, it will be followed by diarrhea and followed by dehydration. So your pediatric population most likely affected with EPEC, enteropathogenic E. coli. Your enteroinvasive E. coli invades the large bowel just like Shigella and also form the actin tail jets just like Shigella. And only 10% of this enteroinvasive E. coli will progress to dysentery. But take note, it is similar to your Shigella. Often, it will present with watery diarrhea. Because it is invasive, it will trigger inflammatory response. There is fever and abdominal pain. The management is to give fluoroquinolones. Best example, ciprofloxacin. Fluoroquinolones, if you can recall in pharmacology, it will inhibit the DNA gyrase, preventing the uncoiling of the DNA, hence the transcription to RNA. So there is decrease in protein synthesis. So fluoroquinolones, remember, are bactericidal in general. So that's for enteroinvasive E. coli. One of the most important And I think one of the most asked subspecies of your E. coli is your EHEC variant, enterohemorrhagic. Enterohemorrhagic association, pag nakakita ka ng hamburger sa situation, kumain ng hamburger, uncooked, o kaya bloody, o kaya kumain ng steak, hindi luto, doon ka na mag-iisip ng baka enterohemorrhagic E. coli yung tinatanong. Hamburgers, petting zoo, papakain ka sa zoo. In the United States, there has been history for EHEC associated with spinach ingestion. And the most celebrated and the most important I want you to remember is your 015787 variant, the most common serotype for your EHEC. The mode of transmission, again, contaminated bovine feces and petting zoos. EHEC, sometimes it will start first with mild diarrhea without bloody stool, then eventually it will present with hemorrhagic colitis and hemolytic uremic syndrome. Hemolytic uremic syndrome is most common in kids less than 5-year old. And we have your plasmid-associated verotoxins, one of the factors that can that you have to remember with EHEC. And this plasmid-associated verotoxins are just like your Shiga-like toxins 1 and 2. Both toxins will inhibit protein synthesis in the large intestine, causing a nicking in the 60 ribosome. Hence, sometimes it presents as invasive, your EHEC. So, whenever you're presented with a case, you're going to think of a bloody diarrhea, but not invasive. Again, let me correct myself. It is a bloody diarrhea, but not invasive in nature. Walang fever, walang PMNs, walang polymorphonuclear leukocytes, your PMNs, because this is not invasive. Again, not invasive yung EHEC. Unlike the Shigella. Okay. Pareho silang may HAS, pero ito walang invasion, not invasive. So remember, the bloody diarrhea in EHEC, is not not invasive. It will present with the fecal leukocyte. And this fecal leukocyte the damage will be secondary to the toxin itself, and it will not promote an inflammatory response. EHEC hamburger. So not invasive, not inflammatory, afebrile, usually in nature. The large intestine is the focus of infection. Bloody diarrhea, you will see a fecal leukocyte. You think of EHEC. Laboratories, very important because you are culturing. You use your McConkey agar. Your McConkey. Antibiotics. The use of antibiotics in EHEC can increase the risk of hemolytic uremic syndrome and acute kidney injury. So antibiotics is a no-no in the management of EHEC. Another variant, we have your enteroaggregative E. coli, less likely to be acidic and less likely clinically correlated. But it has been mentioned in Robbins that it is an important cause of persistent diarrhea with vomiting, low-grade fever, and in the developing world. But just take a look at this. This is a stacked brick-like appearance, okay, of the biofilm attaching to the other and to each other and affecting the enterocytes. Take note also, it will produce your enterotoxin. This figure lifted from Harrison's internal medicine. Again, let's try to review your EHEC type. It is associated with hemorrhagic colitis, hemolytic uremic syndrome. Shiga toxin is the molecular trait. Okay, and the responsible genetic element is your STX1 and STX2 encoding the bacteriophage. ETEC, traveler's diarrhea. So it's traveler's diarrhea. You have your heat stable and heat labile enterotoxin that will cause the diarrhea. Your EPEC, pediatric. Pediatric watery diarrhea persistent in nature and children. So EPEC. Entero-invasive. Uh, Entero-invasive, same epidemiology. It will present with watery diarrhea and occasional dysentery. And enteroaggregative, also, it's associated with traveler's diarrhea and aggressive diffuse adherence. These are the factors and other virulent factor. But I want you to remember your ETEC, EPEC, and EHEC together with entero-invasive E. coli, these four. Okay? So that's, this table just summarizes what I mentioned earlier about your E. coli. So this figure, again, if you want to make your life easier, this figure lifted from Ray Medical Microbiology, your EPEC. Again, watery diarrhea and vomiting, think of infants. EHEC, okay, hemorrhagic colitis, hemolytic uremic syndrome, Shiga toxin. Ay, tandaan yan, E. coli, enterotoxigenic ETEC. ETEC, watery diarrhea, you think of travelers. So you think of your heat labile and heat stable enterotoxin. Enteroaggregative, again, di ko masyadong binigyang importance yan. It is associated with childhood diarrhea. Just take note of this, your pili and your cytotoxins. And the management includes the use of your fluoroquinolones. Enteroinvasive will present with hemorrhagic colitis. There is invasion and destruction of the colonic epithelial cells. Antibiotics may reduce the duration of disease activity. The next pathogen of importance that is associated with diarrhea is the gram-negative rod non-lactose fermenter motile salmonella or salmonella enterica, or salmonella enterica, and other subspecies include Salmonella typhi or Enteritidis. So just take note, this figure is lifted from Lippincott's illustrated flashcards for Salmonella. So again, take note whenever presented with a microorganism, you have to determine the characteristic feature. This is highly motile, unlike your Shigella. This is a non-lactose fermenter and it produces H2S. So the only reservoir for Salmonella enterica subspecies is the humans. And take note, they have the infection is through fecal-oral route, and sometimes there is a carrier state in the gallbladder. So very important to take note that antibiotic preparations that undergo enterohepatic cycling, for example, ampicillin, can be used in the management of carrier state of Salmonella. Decreased stomach acid or impairment of the mononuclear cells. So, the pathogenesis, take note, very important to take note, your typhoid fever or enteric fever. We have your Salmonella typhi, which presents with the milder form, and your parathyroid fever, your Salmonella paratyphi. Organism ingested requires large inoculum. So, large inoculum. It requires a large inoculum, unlike, yes, you're correct, your Shigella, which requires a very low ineffective dose. Infection begins in the ileocecal region and characteristic constipation is the first manifestation of the patient followed by diarrhea. Constipation, diarrhea. So kung may clinical picture ka ng constipation followed by diarrhea with the presence of the biochemical profile or the culture of the microorganism, Salmonella, and that's it. You're going to diagnose Salmonella infection. So just like the Shiga, the Salmonella will reach the basolateral membrane of the M cells. Okay, the basolateral membrane of the M cell, and para siyang in-inject sa lymphoid pocket, it will use the macrophages as a vehicle para mag-travel papunta sa ibang enterocytes. It will travel along other mesenteric lymph nodes, and sometimes, once nakapasok na sa lymph node, nakalipat na sa ibang part ng enterocytes, after 1 week, your salmonella can be found in the blood, can cause septicemia. So again, in week 1, patients have 80% positive blood culture and 25% may present with 25% may present with rose spots. And these rose spots on the abdomen, as you can see in this figure, is associated with vasculitis. Rose spots in abdomen in a patient with typhoid fever due to Salmonella typhosa. Salmonella is a facultative intracellular parasite. So, being an intracellular parasite, anong naalala ninyo? Saan siya mananatili? It will host a mononuclear cell rather than neutrophils. Ano ba yung mga example ng mga yun? Mga pathogens na nag-infect ng mononuclear cells? Mycobacterium tuberculosis, Mycobacterium bovis. They will invade the Peyer's patches in the terminal ileum, and usually the bacterium response is presented in week 1 and in week 2, and the second is associated with vasculitis. So you see here, this is the vasculitis presenting as the rose spots presenting in the upper anterior trunk. Plus, ano ba classic triad ng Salmonella? The classic triad of hepatosplenomegaly, the relative bradycardia, and of course, because this is a bacteria, there is neutropenia. And humans are, again, the known reservoir for Salmonella infection. Once your Salmonella gets into the blood, it can seed to other organs, and you will see signs of sepsis. For example, the patient may present with fever. So again, this is your Salmonella enterica subspecies typhi evasion, how they evade. Okay, they decrease fusion of the phagosome lysosome to your defensins and your V capsular antigen. So with this V capsular antigen, they will allow to withstand oxygen-dependent and independent killing. Salmonella typhi survives intracellularly and can replicate in the macrophages. They are resistant to macrophage killing due to these factors. Okay, remember this. They are resistant to killing. They can hide. Okay, they survive, they replicate in the macrophages, and they're resistant to macrophage killing due to these factors, or Salmonella enterica subspecies. So again, in pathogenesis, remember, biliary system, some of the patients infected with Salmonella, okay, this microorganism can thrive in the liver and in the gallbladder. It will infect, okay, the intestinal tract. So most commonly, the patient can be a carrier for Salmonella. In week 3, you will see a positive culture. If you're going to test for the culture, you want to see Salmonella, week 3 is the best time to do it. Signs and symptoms include fever, headache, abdominal pain. Again, first, commonly associated with constipation, and afterwards, the patient will present with diarrhea. So, what are the different complications of Salmonella infection if it is left untreated? There's necrosis of the Peyer's patches that will cause perforation. It is secondary to the endotoxin that will trigger damage because of the inflammation, thrombophlebitis, cholecystitis. Some of the patient will have pneumonia and abscess formation. Blood, bone marrow aspirate, and tissue biopsy from the rose spots are the diagnostic diagnostic sites for Salmonella infections. The treatment for Salmonella, we have fluoroquinolones or third-generation cephalosporins. For promotive aspect for your preventive medicine, sanitation, and vaccinations are very important in the control of your Salmonella enterica infection. Next question, 70-year-old girl who's being treated with antibiotics for recurrent sinus tract infection presents to the physician with intractable watery diarrhea and cramping. Which of the following is most often associated with this patient's condition? So the patient presents with uh, recurrent, paulit-ulit na sinus tract infection, and you see here that the diarrhea is linked to the treatment the patient received. Most likely the patient is receiving antibiotics. So the best answer here is, what's your diagnosis? The diagnosis of, very good, pseudomembranous colitis. And what is the causative agent for pseudomembranous colitis? Yes, your Clostridium difficile. Pseudomembranous colitis or antibiotic-associated colitis is an acute colitis characterized by formation of, I will show the picture later, adherent pseudomembranes. Ano ba laman ng pseudomembranes na yan? Meron siyang mucus, meron siyang neutrophils, no? And this patient will present with diarrhea. Clostridium perfringens is associated with mga Clostridium double hemolysis. Flesh-eating microorganism. E. coli, of course, for UTI. Staphylococcus aureus, common cause of food poisoning, and Vibrio cholera if it is watery diarrhea. But in this condition, you will see here, may binigay na condition, antibiotic treatment for recurrent sinus tract infection. Yan, you're leaning towards the best answer, which is Clostridium difficile infection. Clostridium difficile infection. Pseudomembranous colitis. This is an acute colitis characterized by formation of inflammatory pseudomembranes in the intestines. It is secondary to Clostridium difficile as the most common cause. There is an overgrowth of Clostridium difficile. Okay, because with the chronic use of antibiotics, you allow Clostridium difficile to grow. This is often caused by broad-spectrum antibiotics. What are the two most important antibiotics associated with pseudomembranous colitis? Yes, you're correct. If you mention ampicillin and, of course, your lincosamide, clindamycin. Given the fact that you know the causative agent, the first thing that you have to do is to stop the medication. And how are we going to treat this? Stop the medication and give the drug of choice for pseudomembranous colitis, metronidazole, and an alternative drug which is vancomycin, oral preparation of vancomycin. So again, your Clostridium difficile, also known as your Clostridioides, okay, is an anaerobic gram-positive spore-forming rod that presents with an exotoxin which manifests a cytopathic effect. The cytopathic effect. And the only reservoir is in the human colon. The mode of transmission, commonly, sino ba yung mga nagkakaroon ng Clostridium difficile? Yung mga long-term hospitalized patient, mga nasa ICU, hospital personnel. No, mga nasa hospital. Kasi gumagamit sila ng antibiotics, long exposure to antibiotics. So this is the pseudomembranous colitis. This is a mushroom-shaped yellow-tan mucosal membranes. You will see here superficial colonies with an underlying pseudomembranes, no? Underlying pseudomembranes. And again, how to diagnose your pseudomembranous colitis? Of course, the best is to detect the toxin in a stool. And the drug of choice is metronidazole and oral vancomycin. You want to preserve oral vancomycin to more life-threatening situation. So you have to start first with metronidazole. Next is your rotavirus. Rotavirus is the most common cause of severe childhood diarrhea and diarrhea-related deaths in the world. Again, rotavirus is the most important global cause of infantile gastroenteritis, and commonly, they affect children between 6 months and 24 months of age. So primarily, the main protection for children within first 6 months of life is through the antibodies provided by the breast milk. And after 2 years of age, most likely it is linked to previous infection to rotavirus. And what is the pathology behind rotavirus, it will cause villus destruction and atrophy of course, of the villus, of the intestines. Hence, there is a decreased absorption of sodium and loss of potassium, causing osmotic diarrhea, electrolyte disorder. So according to the CDC, it is recommended to give routine vaccination for rotavirus. So if you can remember, rotavirus is associated with cases of intussusception, and another contraindication for rotavirus is your severe combined immunodeficiency state. But otherwise, rotavirus is a recommendation. So for parasitic and protozoal infection, take note of these different parasitic infection we have to discuss. Your Ascaris lumbricoides, your giant tapeworm. The two most important cause of IDA secondary to hookworm, of course sila lang naman yon, Necator americanus and Ancylostoma duodenale, and Amoeba histolytica and Giardia lamblia. Following this microorganism, we're talking about diarrhea in immunocompromised patients, HIV/AIDS patient. So let's just discuss them one by one. All right, we have your Ascaris lumbricoides, or Ascaris, or giant, the largest giant roundworm. So mode of transmission, lupa, soil transmitted helminth. Nakakain ka ng itlog ng Ascaris. So infective stage, remember, embryonated, diagnostic, unembryonated. Very important in parasitology to take note of the mode of transmission. Tatlo lang naman ang kailangan mo tandaan. The mode of transmission, apat pala. Mode of transmission, infective stage, nandito naman yan. Halos lahat ng figure na lifted from CDC, makikita natin yung infective stage and the diagnostic stage. And of course, the fourth, kailangan alam mo yung treatment. So Ascaris lumbricoides, it can cause major damage during the larval migration. Take note, pwede siyang magkaroon ng transmigration. Nagkakaroon ng Loeffler's syndrome sa lungs or inflammation with an eosinophilic exudate. Eosinophils, kasi sila ay protozoa. So, ano yung ina-expect mo tumaas? Eosinophils. They are wandering worms, no? Pwede silang palipat-lipat. Due to erratic behavior of the adult worms, pwede sila mag-cause ng hepatobiliary ascariasis and appendicitis. Hypersensitivity pneumonitis kapag nasa lungs, no? Loeffler's syndrome. So these are the two most important, the Necator americanus and your Ancylostoma duodenale. So these are the two most important cause of IDA secondary to worm infection. Infective stage for both your filariform and diagnostic stage is your eggs in the feces. Take note of that. So remember, it can cause microcytic hypochromic anemia. Can you still recall when you say microcytic, the MCB value is less than 80. But normal is 80 to 100. Microcytic, tails, thalassemia, anemia of chronic disease, iron deficiency, lead poisoning, sideroblastic anemia. Does it ring a bell? Yes. Your Loeffler syndrome, we have your Wakana. Your Wakana syndrome is just like an immediate hypersensitivity reaction characterized by pharyngeal itching, hoarseness, nausea, vomiting. Of course, you'll see eosinophilia. Take note of this. We have the eggs in the feces that will be transformed into a rhabdiform larvae that will cause this development. And this filariform larvae will penetrate the skin. Upon penetration of the skin, it will directly go to our intestine and dun sila mag-grow. No? They are suckers. They will cause, their blood suckers will cause iron deficiency. The drug of choice, albendazole. Amoeba histolytica. It is a pseudopod-forming non-flagellated protozoa and is considered as the most invasive parasite among Entamoeba. The mode of transmission, fecal oral route. Infective stage, mature cyst. Diagnostic stage, trophozoites or mature and immature cysts. Tandaan nyo, yan lang naman lagi natatandaan sa mga protozoa. Just remember this picture lifted from CDC. So what are the different, how will Entomoeba histolytica cause infection to human? For example, this figure lifted from Harrison's, you will see a cyst and trophozoites. This no, dumumi, no, nasa stool. The cyst na nasa stool, na infect, na ano yung tubig, na contaminate yung tubig, kinain ng tao, nainom ng tao, magkakaroon ng excitation saan? Sa small intestine that will release your trophozoite that can colonize the large bowel. Now, there is this entamoeba loves your RBC. So you will see one of the signs is the presence of RBC inside the trophozoite. And this trophozoite uh, will colonize the large intestine. In some cases, can cause other extraintestinal manifestation. For example, it can cause amoeba, a liver, amoebic abscess in the liver. Okay? The pathogenesis, we have your gall-lectin, your amoeba pores, and your cystine proteases. So just take note that majority of the infections of Entamoeba histolytica is restricted to the lumen. So you are presenting with luminal amoebiasis. Sometimes these patients are asymptomatic. So again, it can present with amoebic colitis or invasive intestinal amoebiasis when the mucosa is invaded. Again, some of the signs and symptoms will include diarrhea, severe dysentery, and associated complications. Ano ba yung mga complications niya? So nakita niyo, affecting the liver, pwede siya mag-present with perforation, pwede siya mag-present with peritonitis, and amoeboma formation. Amoebic liver disease or amoebic liver abscesses are the most common manifestation of extraintestinal amoeba. So you see here we have different stages. We have your cyst carrier stage and sometimes amoebic colitis. In a symptomatic carrier, the drug of choice is to give a luminal agent. Luminal agent, we have your iodoquinol as one of the best example, best treatment for asymptomatic carrier stage. For acute colitis, we have to give both luminal amebicide and extraluminal amebicide. We have metronidazole plus luminal agent, iodoquinol, paramomycin combination medication. In amoebic liver disease, we have metronidazole, lagi nandyan ang metronidazole kasi protozoa, pinag-uusapan natin, plus luminal agent. So you see there's combination of medications. So in Amoeba histolytica, you will see the characteristic flask shape, Erlenmeyer flask shape ulceration, and the presence of RBCs in the trophozoites for Entamoeba histolytica. So that's Entamoeba. The next the next protozoa is your Georgia lamblia. Pinakamadali ito, no? Makikita mo to. The trophozoite of an old man's face. Old man's face. Motility, falling leaf motility. Okay. This Georgia lamblia is not invasive. What will happen is, they will block the enterocytes. Upon blocking the enterocytes, because you are blocking the villi, the villus, there is a possibility of malabsorption. And commonly, this patient will present with a very fatty, foul-smelling diarrhea. Sobrang baho ng diarrhea ng Georgia lamblia. Mode of transmission, direct oral anal sexual contact. Yes, you're correct. Men having sex with men. Another term for giardiasis, I can recall in what book I've read that. Meron siyang tinatawag na gay bowel syndrome, no? Gay bowel syndrome, and her campakers are also prone to have your Georgia lamblia infection. Again, it presents with a real foul-smelling diarrhea because of malabsorption. Sobrang baho, may malabsorption. It is the most prevalent enteric parasite in the United States and the leading infectious agent in waterborne outbreaks of diarrhea. So your Giardia duodenalis trophozoites can be seen in this corn stain resembling an old man's face. Yan yung characteristic niya, old man's face for Giardia lamblia. So again, ano mangyayari is we have your adhesive disc and your lectin that will facilitate the attachment and avoiding peristalsis. Magkakaroon ng villus flattening, creep hypertrophy, and disruption of the cytoskeleton. And eventually, because of the enterocyte apoptosis, there is malabsorption. Take note, mode of transmission, fecal-oral. Infective stage, cyst. Diagnostic stage, trophozoites. Spectrum of diseases for giardiasis, take note of this. Always ask for history of travel, history of drinking untreated surface water, and commonly affecting children at daycare. With acute infection, it will present with abdominal pain, excessive flatus, utot ng utot na napakabaho, rotten eggs because of the hydrogen sulfide. Because of the malabsorption, the patient will present with the foul-smelling, greasy stool, malabsorption of your fat-soluble vitamins, there is steatorrhea. The treatment of choice is to give metronidazole. If you longer half-life, you have your tonidazole and a luminal agent, nitazoxanide. Another important microorganism or protozoa of importance for diarrhea. Now we're going to talk about diarrhea in patients who are immunocompromised, in particular to your HIV patients or AIDS patients. You have your Cryptosporidium parvum that will present with transient diarrhea in healthy individual and can cause severe life-threatening diarrhea in patients with HIV. Common modes of transmission, kumain ka ng cyst ang galing sa undercooked meat and water. Remember that this cyst is not killed by chlorination. This cyst is actually acid fast in nature. And again, they affect commonly your HIV patient, and this patient will present with severe life-threatening diarrhea. Next is your Isospora belli. This Isospora belli you will see here on the smear stained using your Sill-Nielsen method. It also lead, just like your Cyclospora, it can lead to transient diarrhea in healthy individual. But take note, when the AIDS patients are infected, these are life-threatening. Same same of mode of transmission, ingestion of cyst, fecal-oral transmission. Your Cyclospora cayatinensis, another one, can cause severe diarrhea in AIDS through fecal-oral route. The mode of transmission is fecal-oral route, or ingestion of oocysts in water. Just like your Isospora, this is an acid fast, and the treatment of choice is your TMP SMX, cotrimoxazole. Microsporidia. Microsporidia, again, they are persistent in AIDS patient. They are spores. They contain spores, rather. They are transmitted via fecal-oral route, and there is no proven treatment for this. So again, Microsporidia, Cyclospora, Isospora belli, these are the important pathogens that you have to recall when you're talking about patients, in AIDS patients, presenting with severe diarrhea. So let's discuss gastrointestinal pharmacology, bridging the earlier discussion. Let's give this case, a 20-year-old man with active gastroesophageal reflux disease came into the physician for the second time in 2 weeks complaining of worsening of sore throat. The patient was previously diagnosed with penicillin-sensitive Streptococcus pyogenes on throat culture because he is allergic to penicillin, a cell wall synthesis inhibitor. He was given with ciprofloxacin, a fluoroquinolone. Suspicious of an interaction adjunct top-notch maybe ask the patient if he has taken or been taking any other medications. Which of the following medications is this patient most likely taking? So this question tries to evaluate your knowledge about drug-drug interaction. So the diagnosis of this case is GERD. The patient is being treated with ciprofloxacin for strep pyogenes infection. So most likely this patient is taking which medication? Maybe there is a drug-drug interaction, there is less effect of the drug, of the ciprofloxacin. Your fluoroquinolones, remember, one of the health teachings that you should give to your patient is to avoid taking cation divalent, or in this sense, we have your cimetidine. Cimetidine is the best answer to this question. So let's review your acid suppression therapy. So you see here, this image is lifted from Taula USMLE that will describe how hydrogen ion production is being governed. So we have the vagus nerve, we have the essential key players, your acetylcholine, your gastrin coming from your G cells, and your histamine coming from the enterochromaffin-like cells, which is stimulated via gastrin. You will see here that through vagus nerve, through your parasympathetic stimulation, it can cause the release of your acetylcholine binding to the M3 receptor. Remember, M3, we think of glandular secretion. It is GQ mediated, increasing the level of your IP3 and calcium that will stimulate the hydrogen potassium ATPase. Together with gastrin, it shares the same mechanism of action. It will activate the CCK receptor via GQ mediated secondary messenger, increase in IP3 and calcium, that will also again stimulate your hydrogen potassium ATPase. Your histamine coming from the stimulation of gastrin via coming from the enterochromaffin-like cells will bind to the H2 receptor using the GS coupled receptor, increasing the level of recyclic AMP, and as well increasing the level of your hydrogen potassium or proton pump, no? Increasing the level of your hydrochloric acid. So you will see here the different medications. We have antacids working on this section, together with the proton pump inhibitors working on the basolateral membrane. Your sucralfate, together with misoprostol, they will inhibit, they will further protect the gastric mucosa. Sucralfate, it will coat, okay, the surface mucosa. Misoprostol will act as it's a prostaglandin analog. It will mimic your prostaglandin that will increase bicarbonate production, such as well as your mucus production. So that's your acid suppression therapy in a nutshell. So in the treatment of peptic ulcer disease, we have earlier discussed that PUD, we have different medications used in PUD. We have your antacids, for example, your Mealox, your magnesium, your aluminum, your Gaviscon, your Tums, and your Mylanta. Usually, these acid-suppressing agents are used to address acute attacks of PUD. Same as with your H2 receptor antagonist binding to the H2 receptor, the mnemonic here is the DINE medication, your cimetidine, cytochrome P450 inhibitor that is notorious notorious in causing gynecomastia because it is also an androgen antagonist. So as well with ranitidine, famotidine, and isatidine. And the most effective drug in the management of PUD are your proton pump inhibitors, your omeprazole, usually given 20 milligram per day. We have your lansoprazole, rabeprazole, pantoprazole, esomeprazole, and dexlansoprazole. So these medications are considered as the most potent medication in the management of PUD. Other agents that will serve as mucosal protective agents, we have your sucralfate, prostaglandin analog, your misoprostol, which is the drug of choice for NSAID-induced gastritis, and bismuth-containing compounds or bismuth subsalicylate and the management of H. pylori infection. So we have here your magnesium aluminum hydroxide, your Melox, with the similar drugs calcium carbonate, sodium bicarbonate. They are classified as antacids and they work by a neutralization of the stomach acid by way of reacting to protons in the luminal in the lumen area. Clinical use are peptic ulcer disease. Toxicities include with sodium bicarbonate, belching, metabolic alkalosis, and calcium carbonate can cause hypercalcemia, of course, and renal insufficiency. Magnesium ideally can cause constipation, and aluminum is linked to diarrhea. So, combination of these drugs will cancel its effects. So, remember, it can impair absorption of tetracycline as we have mentioned. We have your fluoroquinolones and itraconazole and iron. Cimetidine is an H2 receptor antagonist. Being a receptor antagonist, it competitively blocks at the level of the H2 receptor. What does it mean in biochemistry? If you are going to increase the level of the substrate, which is your hydrochloric acid, your hydrogen ions, in cases of Solinger-Ellison syndrome, it can compete to the drugs by it can compete with the drugs binding to the H2 receptors. So clinical use, we have nocturnal suppression, the nocturnal suppression of acid. We use your cimetidine, peptic ulcer disease or Solinger-Ellison syndrome, wherein there is increased level of hydrochloric acid secondary to a tumor, your GERD, and dyspepsia. Associated with gynecomastia is cimetidine because of its anti-androgenic effect. And also remember that cimetidine is a potent cytochrome P450 inhibitor. Very important to discuss the drug-drug interaction. If this medication is a potent inhibitor, can you tell me what will happen to the substrates? So the substrate will go up. So it will go up. It will increase the level of the drug. So just remember that your H2 receptor antagonists are effective in the management of nocturnal acid secretion. So next question, a 45-year-old man with a long history of medication, reflux esophagitis, sees his physician for an annual physical exam which reveals a blood gastrin levels 3 times the upper limit of normal. His physician is concerned that the patient might develop atrophic gastritis. Which of the following medication is this patient most likely taking? So most likely this patient is taking, yes, your proton pump inhibitor omeprazole. Omeprazole is a proton pump inhibitor which irreversibly blocks your hydrogen potassium ATPase, or simply known as your proton pump. Clinical use, we have your PUD, Solinger-Ellison syndrome, your GERD, and dyspepsia. But take note of the possible toxicities. There is malabsorption. Remember, it requires an acidic environment for vitamin B12 to be reabsorbed or activated. Remember that is an extrinsic factor as well as the activation of the intrinsic factor. It is also associated with infections, respiratory tract infections, hypergastrinemia as a compensatory mechanism because of a decreased level of hydrochloric acid, and atrophic gastritis. Remember that your gastric mucosa requires an acidic environment in order to grow and to thrive. So similar medications, we have your pantoprazole highlighted in red because of the less drug-drug interaction. That's our omeprazole, proton pump inhibitor. With clinical correlation to internal medicine, according to Harrison's, what are the 3 main roles why we give proton pump inhibitors to patients with bleeding peptic ulcer? This is a favorite Revalida question. So the answer to this is, okay, to maintain an intragastric pH of 6, okay, to maintain the stability of the clot, and to decrease mortality. These are the 3 reasons why we give proton pump inhibitors to patients with bleeding peptic ulcer. So you see here, a correlation to pathology, we have the intestinal metaplasia, right? Associated with chronic GERD. Yes, you're correct. A mix with presence of your goblet cells, that's your Barrett's esophagus. This is the Z line, your squamocolumnar junction thickening, secondary or response to a chronic GERD, that's your Barrett's esophagus. Sucralfate is a mucosal protective agent which binds to the injured tissue, forming a protective coating over the ulceration. It will accelerate the healing of the peptic ulcer and reduce recurrence rate of the peptic ulcer. So sucralfate is clinically used for PUD. Take note that it is highly insoluble and requires frequent dosing with sucralfate. All right. So let's go to another medication, the drug of choice for NSAID-induced gastritis. We have misoprostol. Misoprostol is an analog of your prostaglandin. Remember, physiologically, your prostaglandin works by increasing the level of your bicarbonate and mucus production in the stomach. Hence, it is a protective agent. Also, bear in mind that misoprostol can cause uterine contraction. So, pharmacologically, misoprostol is used as a medical abortifacient together with your mifepristone. So take note that misoprostol is contraindicated to pregnant because it is an abortifacient. Toxicities include abdominal pain, diarrhea, uterine cramping, and miscarriage. That's your misoprostol. The trade name is Cytotec. You're familiar with misoprostol. Next, we have your bismuth subsalicylate or salicylate. Also works as a mucosal protective agent. It forms a protective coating on the ulcerated tissue. It will stimulate the mucosal protective mechanism. It will direct antimicrobial effects and sequestration of enterotoxin. Hence, it's one of the medications used in the management of H. pylori infection. Toxicities include darkening of the tongue and your black stools. So that's your bismuth salicylate. Remember this table. This table is directly lifted from Harrison's Principles of Internal Medicine that will show you the different regimen for H. pylori infection. You will see here the presence of your proton pump inhibitor, your clarithromycin. This is a macrolide and metronidazole. Usually, we give the regimen for 14 days. So another management could be the addition of your bismuth subsalicylate, your tetracycline, and your metronidazole. So remember, these are OCAM, your BMT regimen for H. pylori infection. A 55-year-old woman with type 1 diabetes of long duration complains of severe bloating and abdominal distress, especially after meals. What can you give to alleviate her symptoms? So the patient is having, yes, you're correct. The patient is diagnosed with type 1 diabetes mellitus, there is severe bloating and abdominal pain or causing abdominal distress. Perhaps this patient has an uncontrolled DM, and maybe the patient, being a chronic DM patient, suffers from diabetic gastropathy. So with diabetic gastropathy, there is a decrease in motility of the gastrointestinal tract. So the best drug to alleviate the signs and symptoms of this patient is to give a prokinetic agent. Which of the following amongst the choices is a prokinetic agent? So you're correct if you're going to answer the D2 antagonist metoclopramide. You're familiar with the drug Placil? That's the trade name for metoclopramide. Metoclopramide is a prokinetic agent. Also, do not forget that metoclopramide acts on the D2 receptor, working as an antagonist in the chemoreceptor trigger zone, preventing it is a drug for emesis. Clinically used in patients with cancer chemotherapy, diabetic gastropathy. So remember, the best drug to give is a metoclopramide, a prokinetic agent. We're being asked, what are the substance or type of medications that you're going to avoid naman in patients with DM gastropathy? You're correct if you're going to answer, for example, avoid giving your opioid. Your opioid. It can worsen the patient's signs and symptoms. So metoclopramide Together with domperidone and erythromycin, they are considered as a prokinetic agent. Erythromycin will bind to the motilin receptors. Domperidone is a prokinetic agent. Erythromycin stimulates motilin receptors, increasing gastric emptying and intestinal motility. The drug of choice for diabetic gastroparesis. So toxicities include metoclopramide. With metoclopramide, we have Parkinsonism because of the D2 antagonism, extrapyramidal effects, and hyperprolactinemia. All right, that's for metoclopramide. In clinical correlation, again, I have mentioned earlier what are the different medications that should be avoided because they cause slowing of the gastric emptying, opioids, or GLP-1 receptor agonists. These should be avoided. Psyllium is a bulk forming medication. Kaya kapag dumumi ka, gumamit ka ng psyllium, plok! Kasi it causes bulk formation. No? Mechanism of action, indigestible hydrophilic colloids that will absorb water, forming a bulk, the stool, and it acts as a emollient gel that distends the colon and promotes peristalsis. Clinical use, of course, with psyllium, if you're familiar with psyllium fiber, is for constipation. So the side effect will include diarrhea. All right, so that's psyllium. So let's proceed to another form of laxative, which is a stool softener. We have your Ducosate. Ducosate together with the similar drugs, we have your glycerin suppository, if you're familiar with this, and your mineral oil. They are used to soften the stool material, permitting water and lipids to penetrate the stool. Clinical use, again, we have constipation. So the side effect will, of course, will be diarrhea and aspiration pneumonitis, aspiration secondary to lipid pneumonitis, and malabsorption of vitamin ADEC. Lactulose. Lactulose, if you're familiar, is used in the management of hepatic encephalopathy. The mechanism of action, the soluble but non-absorbable compounds that result in increased stool liquidity due to an obligate increase in fecal liquid. What is the effect of lactulose? Lactulose is also, as I mentioned earlier, is used in the management of hepatic encephalopathy, wherein the gut flora will degrade the lactulose into metabolites. You have your lactic acid, acetic acid, that will promote nitrogen excretion as ammonia rather. It can be used as, also take note that lactulose can also be abused by patients who are bulimic. Again, clinical indications, constipation, hepatic encephalopathy, as I've mentioned. Toxicities include flatus, electrolyte abnormalities, and diarrhea. Bisacodyl. You're familiar with the drug Dulcolax? That's bisacodyl. Bisacodyl is a laxative. It acts as stimulant cathartic medication, which directly stimulate the enteric nervous system and colonic electrolyte and fluid secretion. Usually, this bisacodyl is associated with melanosis coli. What is melanosis coli? There is brown pigmentation of the lumen of the gastrointestinal tract that is non-carcinogenic in nature. Uh, that is secondary to anthraquinone, your lipofuscin causing discoloration of the intestinal lumen. That is a benign condition. This is what you call your melanosis coli, a benign condition or disorder of the colonic pigmentation secondary to accumulation of the brown lipofuscin. And you will see here, these are the examples of what I've mentioned. These are the characteristics of your melanosis coli. Secondary to use of your anthraquinone-containing laxatives such as your Senna or Synacot, you have your melanosis coli. Diphenoxylate, from the word itself, diphenoxylate it contains a fen. It is a highly lipophilic substance used as an antidiarrheal agent. It is a weak opioid. It binds to the opioid receptor in the enteric nervous system. Clinical indications, of course, we have diarrhea, your non-specific, non-infectious type. Usually, diphenoxylate is combined with atropine. Diphenoxylate can cause CNS confusion, euphoria, and dizziness. Please do not use in children less than 4 years old because of the chance of causing paralytic illness. Urmisalamine urmisalamine is a prodrug. It needs conversion to 5. Ursulfasalazine is broken down by the colonic bacterium to become an active metabolite or 5-ASA. This 5-ASA is used in the management of your inflammatory bowel disorder. For example, we have your you have your Crohn disease and ulcerative colitis. Because it acts as an analog of purine, it is inserted in the DNA, can cause bone marrow suppression. It is not useful for treating acute flare-up of the diseases. Or mesalamine, also take note because of this is a sulfur-containing medication. What we have discussed from pharmacology, that if a medication is sulfur-containing, you should shy away it from giving to patients with G6PD deficiency and with allergies to sulfur or sulfonamides. So this figure is the therapeutic management or the therapeutic pyramid approach to the management of inflammatory bowel disease, depending on the severity of the disease. So we see here in mild responsive cases, we start with budesonide, steroid, we have our topical corticosteroid antibiotics and your 5-ASA. When it turns to become moderate, we have your azathioprine, your 6-mercaptopurine, a purine analog. We have the DMARD, methotrexate, the first-line DMARD of choice. For rheumatoid arthritis, we have oral corticosteroids and your tumor necrosis factor antagonists. So we will see here, we have immunomodulators, natalizumab, cyclosporine, and followed by surgery in refractory cases. And that ends our discussion for the GI integration for pharma, patho, and micro. I hope you learned something for this session. Just remember to be patient in studying and correlating these basic sciences, because this will bridge the gap between the basic sciences and your clinical sciences. Very important na nakapag-aral tayo ng basic sciences, mas madali nating naiintindihan ang clinical application. Aim not for success, always aim for significance. Thank you very much. God bless and see you again, mga guys.